Yeah, I have it on. Uh-oh.
Good morning. Welcome to the Legislative Office Building and to the 2025 Health Insurance Rate Request filing hearings. I'm Andrew Mays, the Insurance Commissioner for Connecticut, and before I get started, I do want to touch briefly on the severe rains and flooding that have affected communities across the state. Because of that, I want to remind consumers that the Connecticut Insurance Department Consumer Affairs Division is always available to answer claim-related questions. You can visit the department's website for additional resources, information, and guidance at www.ct.gov/CID. In addition, we will have a virtual claim center that's going to be staffed to answer questions on an open video conference call this Wednesday, August 21st. So that's tomorrow from 1 to 2:30 p.m. If you visit our website, and that's again, www.ct.gov/CID, you will see the link to the virtual claim center. So if anybody is watching and needs help with a claim to get answers, feel free to join us. And of course, for specific inquiries and any answers that you would like to have to coverage questions, or if you need help submitting a claim, please contact Consumer Affairs at the department, and you can do that by phone at 860-297-3900. That's 860-297-3900. Or you can do it by email, and that's relatively easy, insurance@ct.gov. Now back to the program at hand, and I want to thank you all for joining us at the Connecticut Insurance Department's public informational session regarding the 2025 individual and small group health insurance rate filings on and off the Connecticut Exchange, Access Health Connecticut. We are joined today by representatives from Anthem, United Healthcare, and Connecticut. And just to give you some background, the weighted average requested rate increase in the individual market for all health insurance carriers, it's 8.3%. Anthem is requesting an increase of 9.0%. Connecticut Benefits is requesting an increase of 7.4%. Connecticut Insurance Company is requesting a 12.5% increase. And Connecticut Inc., an HMO, is requesting an increase of 9.1%. Now, the weighted average requested rate increase in the small group market for all health insurance carriers is 11.9%. And I do want to remind you that in our state, the small group market is defined as employers with 50 or fewer employees. Anthem is requesting a 13.6% increase. United Healthcare is asking for a 9.0% increase. Oxford Health Insurance Incorporated requests are 8.9%. And Oxford Health Plans of Connecticut, which is an HMO, is requesting a 5.1% rate increase. Copies of the filings for all the carriers, Anthem, Connecticut, United Healthcare, Oxford, and related documents have been posted on the Insurance Department's website for public review and comment since June 7th. And just to put this in perspective, the proposed weighted average individual rate request this year, that 8.3%, it compares to 12.4% in 2024. And for the proposed weighted average small group request, it's an 11.9% increase, as I said, and that compares to a 14.8% in 2023. Sorry, the 12.4% was 2023. And the health plans cover, just so we know, because it's always a question of concern, we've got lots of big businesses that may have ERISA plans that are not covered by these hearings. These health plans cover approximately 200,000 Connecticut residents. The CID is currently conducting actuarial reviews of each filing to determine if they're appropriate. In September, we will decide whether to approve, reject, or modify the requests. And just to repeat, most Connecticut residents are covered by plans regulated by the U.S. Department of Labor. Those are the ERISA plans that most large employers have, or care provided by either Medicare or Medicaid. And the state insurance department does not regulate those plans. Those plans are not the subject of the hearing today. Now, I just want to introduce some of the key members of the CID staff who are here today, and that we include, just to my right, Paul Lombardo, who is Assistant Deputy Commissioner and Director of the Life and Health Division. Two to my left, Wan-Chen Chu, Chief Actuary and Assistant Deputy Commissioner. Trisha Dave, to his left, is a Life and Health Actuary Supervisor. Sarah Mu, to her left, is a Life and Health Actuary. To my immediate left is Deputy Commissioner Jared Koski, and two down on my right, Jen Dowdy, who is counsel for the Life and Health Divisions. Now, just to let you know how things will go today, we are going to begin with three separate presentations from Anthem, United Healthcare, and Connecticut on their respective rate requests. Each will run between 10 and 15 minutes, and they will cover the individual and small group plans, both on and off the exchange market. After those presentations, we will hear a presentation from the Office of Health Strategy, whose Executive Director, Dr. Deirdre Gifford, is with us here today. And then the CID will have the opportunity to question the applicable companies. After that, the Attorney General, the Office of Health Strategy, and the Office of Healthcare Advocate together will have in all an hour to speak. And then we will hear from the chairs and the ranking members of the Insurance and Real Estate Committee. Elected officials who have signed up to testify will follow for up to 5 minutes each, and then members of the public who have signed up will follow them, and they will each have 3 minutes. Just for some housekeeping, when speaking, please begin by introducing yourself and address all comments directly to me. To ensure that everyone gets a chance to participate, please focus your remarks on the pending health insurance rate filings that are under review by the CID. If you've submitted written comments, as many have, and plan to speak, please provide a summary rather than restating your full written comments. If you're at the table or online, please mute your microphone when you're not speaking, and please silence your electronic devices for the entirety of this meeting. Now, this past April, the CID released its annual bulletin, which is HC-90-24, outlining the health insurance rate filing guidelines for companies providing individual and group insurance policies in Connecticut. We invite everyone who's interested to explore this bulletin, and it's available on the CID website, again, www.ct.gov/CID, under resources. The CID reviews all rate filings in accordance with applicable provisions of the Connecticut state law. We are an agency that follows the law to the letter, and the only standard under law that we can use to evaluate the rate requests are that these requests must not be excessive, inadequate, or unfairly discriminatory. Under the Affordable Care Act, the minimum loss ratio, and that's the ratio of benefits to premiums for individual and small group coverage, is 80%. Because Connecticut's requirements align with the rate review requirements and the Affordable Care Act, the federal government has designated Connecticut as an effective rate review state. As a result, the federal government relies on the review by the CID of rate filings pertaining to health plans subject to the Affordable Care Act. The CID's review of each filing includes a comprehensive actuarial analysis in accordance with actuarial standards of practice. Among other items, our team analyzes trend components, including unit cost, utilization, and severity, while also evaluating trends against historical data from prior rate filings. Now, I would like to welcome representatives from the three carriers we have with us today. From Anthem Blue Cross Blue Shield, we have Brandon Rousseau, who is a sales director for the individual and small group market for Anthem Blue Cross and Blue Shield in Connecticut. Tu Nguyen is a pricing director for Anthem Blue Cross and Blue Shield. From United Healthcare, we have Paul Brandt, who is a vice president for sales in Connecticut. Over Zoom, I think we will have Michael Dubrowski, who is senior director of actuarial services. And here we have Matthew Flood, who is vice president of network contracting for New England. And from Connecticut, we are joined in person by Mark Mador, who is the president of Connecticut, and Brandon Ritt, who is the VP actuarial for Connecticut. We will now transition to the carrier presentations, starting with Anthem, followed by United Healthcare, and ending with Connecticut. Let's begin with Anthem. Anthem?
Brandon Rousseau, Anthem Blue Cross Blue Shield. Good morning, Commissioner Mays, members of the Department of Insurance, members of the Connecticut State Legislature and Connecticut officials, and members of the public. Thank you for the opportunity to be here today. My name is Brandon Rousseau, and I am here on behalf of Anthem Blue Cross and Blue Shield in Connecticut. I serve as Anthem's sales director for the individual, small group, and large group commercial segments. Joining me is Tu Nguyen, Anthem's lead in actuarial strategic planning. We are here today in representation of Anthem Blue Cross and Blue Shield to discuss and present our proposed rate adjustments. I wish to assure you all that our proposed rate changes are aimed at ensuring the long-term sustainability of providing affordable, accessible, and high-quality healthcare services to all of our individual and small group policyholders in Connecticut. At the outset, I would like to say we understand and appreciate that the insurance department's charge of reviewing individual and small group rate applications is always complex. In an uncertain environment, the department must ensure that the rates requested meet the statutory criteria requiring that they be adequate and are not excessive or unfairly discriminatory. A stable insurance market is dependent on products that create value for consumers through premium rates built upon a known set of conditions that enable the broad spreading of risk. Anthem is here today to present our 2025 individual and small group rates. Anthem is seeking a 9.0% average rate increase for our individual plans, which ensure approximately 63,000 members, and a 13.6% average rate increase for our small group plans, which ensure approximately 38,000 members. We would like to reiterate that we are the only carrier that continues to participate in all segments of the health insurance market, and our 2025 rates for individual and small group are overall the lowest of the carriers. What distinguishes Anthem is the balance we strike between national scale and local presence. This balance allows us to deliver industry-leading innovative products, distinctive service, simplified transactions, and world-class technology with the benefit of local expertise and experience from our over 1,500 associates who live and work here in Connecticut. We have approximately 113 million members nationwide, with more than 1.16 million members here in Connecticut alone. Anthem is proud to have been a part of the Connecticut healthcare community for 88 years. Last year, Anthem and its parent company's foundation had $105 million in open community investments in Connecticut and across the country, including support locally for the Governor's Prevention Partnership and Account the Kicks maternal health campaign. We also sponsor many local charities in the state, including the Greater New Haven Heart Walk, the Boys and Girls Club of Greater New Haven, the Diaper Bank of Connecticut, the Ronald McDonald House, and the Make-A-Wish Foundation, just to name a few. Our unique business model allows us to maintain a strong local presence, including a fully dedicated Connecticut leadership team. Our local team understands and meets customer needs and builds positive long-term relationships with care providers and our community. Our provider network includes all of the state's general hospitals and over 30,000 providers, including primary care physicians, specialists, APRNs, and more. Now, turning to our specific rate applications, they reflect what we consider to be the most significant challenge facing the marketplace, the increasing cost of healthcare. There are many factors that drive our premium request. Year to date, both medical and pharmacy costs are trending up as compared to the prior year. Behavioral health utilization continues to run high across all service categories, including inpatient substance abuse disorder treatments and outpatient and office-based therapy programs. Anthem has and continues to work to ensure access to affordable and quality healthcare. Anthem's commitment to transforming healthcare is built on the foundational belief that by driving innovation, we can deliver great value for our members and member and provider partners, and ultimately improve the sustainability of the system. Our strategic approach is deeply rooted in this partnership framework by contracting for outcomes, collaborating for success, and connecting for health. I would like to highlight our Enhanced Personal Healthcare Program, or EPHC, as Anthem's main value-based payment arrangement for the commercial population, and is also the nation's largest value-based solution tailored to meet local market needs. EPHC is designed to improve quality and control cost of care trends by focusing on prevention and wellness, offering personalized plans, and coordinating treatment across the care spectrum. These services include care planning, enhanced access, such as responding to emails or offering web-based visits, and follow-up with patients via phone or email to make sure they fill new prescriptions. This type of proactive clinical coordination improves health and reduces costs. We are seeing meaningful progress when comparing critical health indicators for our commercial consumers in value-based arrangements to indicators for those who are not, including a 2.9% increase in medication adherence for cholesterol, a 6.5% increase in breast cancer screenings, a 7.1% increase in colorectal cancer screenings, and a 7.7% increase in well child visits for the first 30 months of life. The EPHC program has been so successful that we recently redesigned the program to 1, align with quality measures used by the state of Connecticut and CMS, 2, include more outcomes-based measures, and 3, provide additional incentives for quality measure performance. When providers meet quality and cost performance standards for their attributed patients, they are rewarded with shared savings payments. In 2024, a little more than half of our providers in Connecticut are now part of this redesigned EPHC program, and we continue to try and meet providers where they are in their value-based care journey so that they too can begin to share in the savings that participation in EPHC can produce. We believe that the best means of addressing unit price variation is to move toward a different way of paying for healthcare, shifting reimbursement from volume to value. Across the country, Anthem has nearly 200,000 care provider organizations participating in value-based payment arrangements. In Connecticut, we have made significant progress where 67% of our medical spend for fully insured commercial and Medicare Advantage health plans are in value-based care, and 43% spend is in shared risk contracts. I would be remiss if I didn't add that as part of the cost of healthcare in Connecticut is the ever-increasing number of more expansive mandates and assessments that are being passed. A prohibition on prior authorization will go into effect on January 1st, 2025, which will allow a member to get one prior authorization for a prescription drug for almost any condition, which will no longer allow the health insurer to perform ongoing review for medical necessity. This was an initiative that was promoted by the drug companies that will increase premiums and, more importantly, hinder insurers from doing the important work of keeping healthcare costs down. Every year, we see new drugs and technologies that weren't there the year before, and while these new treatments may be incredibly valuable to health outcomes down the road, they come with a price today. Healthcare is not a stagnant market for services. It is constantly innovating and evolving, which is incredibly important, but it isn't cheap. Our utilization review policies strive to implement value-based coverage, meaning we underscore evidence-based treatments and practices that support the tenets of the ACA in terms of the right care at the right time at the right place. State benefit mandates also increase consumer costs. The CBIA estimates that Connecticut residents pay an additional $2,085 in premium costs because of the state's 68 health benefit mandates. State health insurance assessments also increase consumer costs. There's an increase in overall assessment for the function of various state agencies that are solely borne by the fully insured premium members. While the work of these agencies might be laudable, these assessments continue to grow and are being paid for by those who are on fully insured plans. For Anthem, these requirements equate to 5 to 6% of our 2025 premium request. This includes the exchange user fee of 1.85% that is assessed to the entire individual and small group populations, both on and off exchange. While Anthem fully supports providing members with access to healthcare, these additional state mandates increase costs, with the individual and small group markets bearing the cumulative burden of these increases. Lastly, employers, individuals, and families purchasing healthcare coverage entrust health plans to manage care and ensure that members receive the right care in the right setting at the right time. Today, vital tools used by health plans at the request of insurance purchasers are under attack. Members of the Connecticut legislature seek to pass legislation that, while laudable in many instances, do make insurance more expensive and less competitive. By way of example, the following bills were debated. A prohibition on prior authorization, again, will go into effect on January 1st, 2025. This will allow a member to get one prior authorization for prescription drug for almost any condition and will no longer allow the health insurer to perform ongoing review for medical necessity. This was an initiative, again, that was promoted by the drug companies, and it will increase premiums and, more importantly, hinder insurers from doing the work of keeping healthcare costs down. Tools used by health plans at the request of insurance purchasers are also under attack. Utilization management. Laws and regulations should not impede issuers' ability to conduct reasonable utilization management. Health plans use prior authorization in limited circumstances to lower patients' out-of-pocket costs, protect patients and prevent misuse, overuse, and unnecessary or potentially harmful care, and ensure that care is consistent with evidence-based practices. Without these important tools, health plans will be left with few, if any, strategies to effectively drive quality and safety, ensure proper utilization, and rein in unnecessary spending. This will result in employers and consumers bearing the brunt of increased costs through higher premiums. This past legislative session, the actuarial firm Pasco Advisors was retained by Anthem to conduct an independent analysis concerning the healthcare cost implications of Connecticut Senate Bill 6. The analysis found that limiting health plans' ability to use prior authorization would result in cost increases for Connecticut residents, a $12 to $17 million annual increase in healthcare costs for Anthem fully insured members, and a $14 to $20 million annual increase in healthcare costs for the Connecticut State Employees Plan. Benefit mandates. Connecticut requires coverage for more than 64 specific treatments or services, including some that go beyond evidence-based guidelines recommended by major national healthcare organizations. While the cost of some mandated benefits in isolation may be relatively small, their collective impact drives up the cost of insurance coverage for every person in Connecticut. Often when these mandates are introduced as bills, there's an understanding amongst involved legislators that there indeed is a cost to them, but it is typically dismissed as de minimis because it is only a 1 to 2% cost increase. However, over the years, these mandates add up in the aggregate and impose significant costs on the overall market. As mentioned earlier, the average cost per fully insured policy is $2,085 because of state mandates. The ACA contains a provision that the state general fund will pay for any mandates that are not contained in the essential health plan. Connecticut has never enforced this. There are 2 states that are defraying the cost of state mandated benefits, Utah pays about $2 million per year to reimburse issuers for costs related to providing ABA therapy, and Maine will reimburse issuers for costs related to providing infertility coverage on or after January 1st, 2024. Prescription drug coverage mandates. We know that drug prices continue to increase, and drugs are the second highest expenditure of healthcare dollar next to hospital costs. Health plans use several tools to control drug costs while also ensuring consumers have affordable access to medications to address their conditions. This includes step therapy protocols and formularies. However, in Connecticut, constraints on mid-year formulary changes enable drug manufacturers to raise the price of prescription drugs, driving significant cost growth while restricting payers' ability to contain costs. We trust that the information presented during this hearing will assist the Department of Insurance's review of Anthem's rate application. As already noted, Anthem, like all health insurers, is required to have rates that are adequate and not excessive or unfairly discriminatory. We take that obligation seriously. Offering products at adequate rates to cover the underlying risk of the population served is necessary to meet our members' commitments and ensure market stability. We now welcome any questions the department might have. Thank you.
Thank you, Anthem. We will now move on to the next presentation, which is from United Healthcare.
Thank you. Good morning, Commissioner. I'll ask Mike Dubrowski to make our opening comments via Zoom.
Thank you, Paul, and thank you, Commissioner. Good morning. My name is Mike Dubrowski, and I'm an actuarial director at United Healthcare. I'm responsible for the 2025 Connecticut Small Group ACA rate filing submitted by United Healthcare and Oxford Health. Joining me today is Paul Brandt, the Vice President of Sales, and Matt Flood, the Vice President of Network Contracting. It is an honor to serve over 15,000 small group ACA members in the state of Connecticut, and a privilege that we do not take lightly. It is our mission to help people live healthier lives and help make the healthcare system work better for everyone. We work with healthcare professionals and other key partners to expand access to high quality care, so members can get the care they need at the lowest price possible. Today, I'd like to provide an overview on our proposed 2025 small group ACA rate changes and discuss the major drivers of these proposals. In Connecticut, we offer more than 100 unique medical plans across all metal tiers to small group employees. All plans are available statewide in Connecticut and allow national access to one of the largest provider networks in the nation. Overall, we are requesting an 8.9% average rate increase for Oxford Health Insurance, a 5.1% average rate increase for Oxford Health Plans, and a 9% average rate increase for United Healthcare Insurance. United Healthcare and Oxford Health are requesting the lowest rate increases in the Connecticut ACA small group market for 2025. These rate requests are a direct reflection of the rising medical costs that carriers, including United Healthcare and Oxford Health, face in today's healthcare environment. Although we strive to keep our rates as low as possible to succeed in Connecticut's competitive environment, we must also ensure that rates are adequate to cover these rising medical costs. These rising medical costs expand across many services, but some of the biggest drivers include outpatient surgery, infusion services, GLP-1s, skin and mucous membrane agents, and behavioral health services, which have seen significant increases in utilization in recent years. In addition, healthcare providers are demanding larger negotiated contracts at renewal, and healthcare utilization continues to rise. United Healthcare has always been a leader in cost management initiatives, and we continue to focus on driving affordability to our members through a variety of programs and policies aimed at improving the total cost of care. Programs include, but are not limited to, value-based provider contracting, utilization management programs, wellness and disease management programs, and an increased focus on technology and health. Although these initiatives have made significant strides in reducing utilization and unit costs, medical and pharmacy trends remain high. I apologize about my camera. When I click start video, it says that I need to enable camera access in my browser address. I apologize. Would it be okay if I keep going and then try to figure that out in the meantime?
Yes,
Please
Mike,
continue.
that's fine.
Okay, thank you. Under the Affordable Care Act, insurers are required to spend at least 80% premiums on medical expenses. Under our current rate request, we project that over 87% of the premium dollars that we collect will be spent directly on medical care, quality improvement initiatives, and taxes. Over the past 3 years, over 87% of our premium dollars have been spent directly on medical care. Furthermore, past rate suppression continues to increase the financial pressures that we face. We simply have not received rate approvals necessary to keep up with these high medical trends, requiring larger increases with each passing year. We feel fortunate to be able to work alongside an insurance department that emphasizes the importance that rates should not be excessive, inadequate, nor unfairly discriminatory. I'm confident that our requested rate filings meet each of these criterion. Finally, I just want to close by expressing gratitude to both our members for trusting us with their healthcare needs and to the Connecticut Insurance Department for its continued collaboration and for allowing us the opportunity to address these items today. Thank you.
Thank you, United. Next, we will have the presentation from Connecticut.
So good morning. My name is Mark Metter, and I am president of Connecticut. By my side is Brandon Riff, who, as Commissioner Mays noted, is vice president and our appointed actuary at Connecticut. We appreciate the opportunity to appear before you to participate in this important discussion about the drivers of our requested premium rate increases in the individual market. The main point we want to highlight today is that the amounts we pay to hospitals, pharmaceutical companies, and other healthcare providers determine the cost of the premiums to our members. These costs are increasing as hospitals, pharmaceutical companies, and other providers demand higher reimbursement for the healthcare services and supplies that they provide. Connecticut has seen significant provider consolidation in recent years, making contract negotiations more difficult as providers gain market power. While recent helpful legislation in Connecticut has prohibited hospital systems from imposing certain contractual provisions to leverage that market power, some health systems persist in using anti-competitive contracting practices that contribute to higher costs. For example, some use their market power to insert revenue neutrality clauses in their contracts. These clauses restrict choice and require the use of higher cost alternatives while increasing healthcare costs for individuals, families, and employers. In essence, if a carrier develops a less expensive way for members to access care, these revenue neutrality clauses require that the carrier compensate the system in some other way for the revenue loss due to the cost-saving measure. Our filed rates reflect our increased costs. We have requested rates necessary to continue Connecticut's mission to create healthier futures for our customers and the communities we serve. That mission started when Connecticut was founded in 1981 by a group of physicians seeking to offer a better health insurance option for employers and residents of our state. As a reminder of Connecticut's commitment to the state and its residents, after the passage of the Affordable Care Act, Connecticut stepped forward to become part of the new health insurance marketplace here in Connecticut. We have renewed that commitment year after year, as some other carriers have dropped out or refused to participate. As a result of our deep commitment to the state, Connecticut continues to be the market leader in the individual segment, covering more Connecticut residents than any other insurance carrier. We understand well that for many individuals and families we serve, the individual market is the only option for accessing the health coverage they need, and we take that responsibility very seriously. Please allow me now to directly address the question of our requested rate increases for 2025. For an insurance program to be sustainable, rates must be adequate to protect or provide for the payment of claims and the cost of administering the program. Our proposed rate increases reflect the healthcare costs of the exchange members we serve. As described above, the primary driver of our requested premium increase is medical trend, which is the increased cost of reimbursing healthcare providers for the services they provide to our members and the utilization of those services, such as emergency room visits, hospitalizations, office visits, radiology, pharmaceuticals such as infusion therapies, and prescription drugs. On the cost side, some health systems in our state have requested that we increase their contract reimbursement by more than the state's cost growth benchmark. As I mentioned earlier, the hospital system consolidation in our state has made these negotiations more difficult. At the same time, Connecticut has always been proactive in managing costs. We work with hospitals, doctors, and other medical providers to help control costs and improve healthcare outcomes for our members. The rates we have filed reflect the following steps that we have taken. We are engaging medical providers throughout the state in accountable care organizations and other value-based payment arrangements. We are working with physicians and hospitals to make decisions based on medical evidence. We're investing in disease and care management capabilities that target members at high risk for chronic conditions with a focus on social determinants of health and the diverse cultural needs of the people we serve. We are also accelerating the delivery of well-being and disease prevention programs. In addition, we have been enthusiastic partners with the state to develop solutions that reduce costs, expand access, and create a better health for our community. We have collaborated with the state and the legislature to expand eligibility of the Covered Connecticut program, which leverages Access Health CT to provide no premium, no cost share plan designs for certain low-income customers who are not or are no longer eligible for Medicaid. The resulting changes are expected to maximize state and federal dollars to ensure the program's longevity. We've worked with the Office of Health Strategy on the health cost growth benchmark. I was privileged to participate in OHS's Healthcare Benchmark Initiative Steering Committee. This committee advises on all benchmark matters, including the primary care spending target and quality metrics. And we are working with OHS to drive more primary care to catch diseases at their earliest stage and improve our members' quality of life. Throughout its more than 40-year history, Connecticut has worked to be a strong partner to our members, the state, the consumer, and business communities, doctors, and other healthcare providers. And finally, to support the future growth of Connecticut, our parent company, Emblem Health, has agreed to sell Connecticut to Molina Healthcare. Molina Healthcare shares a similar origin story to that of Connecticut, being founded by a physician and consistently giving back to improve the health and well-being of communities. Molina Healthcare has a strong track record of participating in public programs and being committed to the goal that Connecticut has worked tirelessly to support, and that is expanding affordable access to healthcare. We appreciate the opportunity to explain our filing and look forward to your questions.
Thank you, Connecticut. And as you may know, the state has been working diligently on a comprehensive plan to restrain the cost growth increase for medical care, thus holding down premiums, making healthcare more accessible and affordable for everyone. Leading that effort has been Dr. Deirdre Gifford, who's the Executive Director of the Office of Health Strategy. And I'm going to ask her to briefly present about 10 minutes or so on the current state of the cost growth benchmark. Dr. Gifford?
Thank you very much, Commissioner. Thank you for inviting the office to participate in this event. Thanks to the carriers for your participation. We very much look forward to engaging in further conversation. We appreciate the opportunity to talk about the Healthcare Benchmark Initiative. And I just wanted to say that I think it's emblematic of this administration's approach to healthcare affordability, that this has been a multi-agency effort. At OHS, we collaborate with CID on a regular daily, weekly basis and to talk about affordability. We work with our colleagues at the Office of the Attorney General, at the Department of Social Services, the Healthcare Advocate, the Office of Policy and Management, and more. This is a priority. Healthcare affordability is a priority for the Lamont administration. And we appreciate this opportunity to talk more about one such effort, which is the Healthcare Benchmark Initiative. Next slide. This is some context for all of us as we think about the rate increase requests that are before the department today. This is data from a 2022 survey by Value Hub. It was carried out among 1,200 Connecticut residents. It will be updated next year, we hope. But this gives you a sense of the struggles that our residents are facing to afford their health care. I recommend the whole survey to all of you. The citation is at the bottom of this slide. These are a couple of key facts. 33% of our residents who responded to the survey said that they are struggling to pay their medical bills. 46%, and this is the statistic I have on a sticky note on my computer monitor, 46% of our residents are delaying or foregoing care because of cost. And 78% of Connecticut residents are worried about their ability to afford healthcare expenses in the future. So this is the context of our work on healthcare affordability at OHS, and I think provides some important grounding for our conversations today. And by the way, I'll say that this is a Connecticut survey, but it's very consistent with KFF surveys that have been done nationally about the burdens that healthcare affordability are placing on Americans. Next slide. So what is our cost growth benchmark? Our benchmark initiative was established in March of 2020 by Executive Order number 5 and later codified in Public Act 22-118. The cost growth benchmark represents the targeted annual per person growth rate for Connecticut's total healthcare spending. So we look at aggregate spending divided by total individuals in 1 year, and we compare that to aggregate spending divided by total individuals in the following year to come up with our per person growth rate. The goal is very simple of the benchmark. Many of you mentioned it in your introductory remarks. The goal of the benchmark is to slow the growth rate of healthcare spending and make healthcare more affordable for the residents of Connecticut. Next slide. So, given the range of rate requested increases that we've heard this morning, weighted average of 8%, we in Connecticut have set a benchmark for 2025 of 2.9%. So these increases are between 3 and 4 times what the state has set as a target for per person growth in 2025. We will be undertaking a process beginning this fall to set the benchmark values for the next 5 years. 2025 is the last value that we've set. We are required at OHS to review the benchmark values annually for the impacts of inflation. And so you'll see that we did adjust the 2024 benchmark to 4%. Based on the very extraordinary levels of inflation that we saw in 2022. We anticipate that that adjustment will be a rare event, but we did make that change on a temporary basis for 1 year. Next slide. I'm sorry that you can't see those numbers, but this is just to show you that there are now 8 cost growth benchmark programs around the country. Connecticut is not the only state that's doing this work. Massachusetts was the first in 2012. California, I believe, is the most recent, and their benchmark program will go into effect in 2026. But on the right-hand column, if you could see it, you would see that our benchmark values are pretty much in line with the values that are set in the other benchmark states. They range from the high 2s to the low 3s. Each of us uses pardon me, a slightly different methodology for setting our cost growth benchmark, but we've all landed in a relatively similar place, well below 5% as a targeted per person growth. In Connecticut, our benchmark is set using two measures. We look at projected growth in median household income, and then we look at the projected growth in the state's economy, and we do a blended average of those two things, weighted more heavily towards household growth. And that's how we arrive at the benchmark values. Next slide. This is the state's performance against the benchmark. The horizontal lines on the graph are the benchmark values. So in the middle bar is the first year that we reported our performance against the benchmark. The benchmark value was 3.4% in 2021. And the state's growth rate in per person spending was 6.4% overall. Notably, commercial spending growth was 18.8% between 2020 and 2021. It's not shown on this slide, but obviously the changes in healthcare spending between 2020 and 2021 are very unusual. We saw declines in spending, as you can see there on the left, which is the spending in 2020, the year of the first year of the pandemic. And then we saw a rebound in spending in 2021, which accounted for a lot of the increases. However, we reported our second year just recently this past March, the 21-22 spending changes. Our benchmark value was 3.2% and the state exceeded the benchmark, although we came much closer in 2022 with an overall increase of 3.4%. Next slide. So when we dig into what's behind our spending increases in Connecticut, and many of you have mentioned this in your presentations, we really find that what's driving healthcare cost growth in Connecticut is price. There are some changes in utilization in some sectors of the healthcare market, but generally what's driving our increases is price. And this is data from the Healthcare Cost Institute, which shows a comparison of healthcare prices in Connecticut to the national median. The tiny little depiction of Boston there shows that healthcare prices in Boston are about 9% above the national median. In Providence, they're about 5% below the national median. In Hartford, New Haven, and Bridgeport, they're 17, 22, and 28% above the national median, respectively. So our healthcare prices in Connecticut are significantly higher than in the rest of our neighboring states and around the country. Next slide. And you can hit advance one more time. The two things, as many of you have mentioned, that are driving these price increases are pharmacy spending, and in particular, retail pharmacy and hospital price growth, and in particular, outpatient hospital spending. So here you can just see the annual growth of payment per unit for retail pharmacy. And we see a trend in the bottom half of this graph. We see a trend between 5 and 7% increase in annual spending in retail pharmacy, well above our benchmark, making it very difficult for us to meet the benchmark with this kind of trend. And in the last column, you can see that the change in utilization has been very small or negative. So again, we see that price is driving the increase in retail pharmacy, not increases in utilization overall. And my last slide is the analogous information about hospital spending. Now, let me explain what is shown on this slide. This is a snapshot from a website called the National Academy of State Health Policy Hospital Cost Tool. And what this tool allows you to do is look at individual hospitals and look at states and compare relative prices by hospital or hospital system. The pink bars that you see here, each bar represents a hospital, the 27 acute care hospitals in Connecticut. Each bar represents the relative price, commercial price paid to that hospital, both inpatient and outpatient, relative to Medicare. So on the left-hand column, you can see, I think this graph goes up to probably 300% of Medicare. We have one hospital that is paid well over 300% of Medicare. But what you can see in the pink bars is that there is tremendous variation between about 185% of Medicare up to 340% of Medicare in what we pay our hospitals in Connecticut. And that's something I hope to be able to discuss with the carriers later on. The green bars are a calculation that's done by the National Academy of State Health Policy and what's called the hospital break-even. They look at the hospital's costs as reported to Medicare on their Medicare cost reports, and they calculate what the commercial payment rate would need to be in order to break even with no profit based on their reported costs. So when you compare the pink line to the green line, you see the differential between what's paid on average by commercial payers in Connecticut and what is calculated that the hospitals would need to be paid in order to break even. So again, you see there's tremendous variation by hospital between the break-even point and their commercial payments. And so in conclusion, Commissioner, I just wanted to bring out the point that what's driving our ability in Connecticut to meet our cost growth benchmark is mostly price, and in particular, prices paid for pharmacy and hospitals. Thank you.
Thank you for your presentation and for your work, Dr. Gifford. I look forward to your questions within the next hour or so of the assembled regulated entities. It is always a little disconcerting to see that prices for healthcare, and we have a fabulous healthcare system, but to see that the prices for healthcare in Connecticut so exceed the prices for healthcare in various states. And we do need to address those prices in order to be able to address insurance premiums. And with that said, I will now move on to questions. And since I'm in the chair, I will begin. My first question is going to, well, actually my questions are all going to be for everyone here, but it's going to be slightly different for United and for Anthem. And for United and Anthem, I would note that there continues to be significant activity in the Connecticut marketplace, and this does include small group market exits. We've had a number of those over the past few years, and a potential change in ownership for one of our individual carriers. What are the challenges of the Connecticut market, and will you state here your commitment to a market in the future? But I am going to begin with Connecticut, so I will ask you to answer that after I ask Connecticut. As you mentioned, there is a potential change in ownership. I'm presuming that part of that is that the new owners see an opportunity in Connecticut. So while we are well aware of the challenges, what opportunities do you see? And again, I know you've stated your commitment, but would you be willing to restate your commitment to this Connecticut market in the name of the new owners? Mark?
Yeah, so on behalf of Connecticut, and I really can't speak on behalf of Molina at this point, as you know, it's a proposed transaction. It's not going to close until next year, assuming it's approved. But I can definitely give you our commitment at Connecticut that we are totally dedicated to the individual market, and we will continue to be. It's a attractive market to us, and I do know it's an attractive market to Molina Healthcare. So we are completely dedicated.
Thank you. And as one of the one of the companies that exited the small group market, what's your view on that market in Connecticut?
Yeah, we did that reluctantly. We had been in the small group market for years, and we just couldn't, given the increases that it would require in our rates, we couldn't continue to maintain a competitive position in the small group market. So, I think that market probably does need some reform. Again, we still sell level funded small group products, which are self-insured products in that market. But from an insured standpoint, we just could not maintain a competitive product there. And so we decided to exit.
Thank you. Now I will turn first to United and then to Anthem, if you could answer the original question.
Thank you, Commissioner Mays. Along the first lines, we certainly are committed to remaining in the small group market in Connecticut. In regards to the environment, it's always been a challenge. Healthcare is always a challenge. And what we like to focus on are solutions. And the solutions relate to affordability of care, but also access. So access has to remain very high. We also need to identify affordability. We were here about a month ago speaking about ways that we may be able to do that. And one of them is to really improve in our way with engaging with a member, but also having a member engaging in their own health to make good decisions that perhaps will provide either better environments, which may be outpatient or other areas, or also it could be just improving their own health in general. So we remain committed to the market, but also remain committed to helping a member become more healthy and have a better lifestyle.
Yeah, and for Anthem, very similar responses, both Connecticut and United. We are fully committed to the individual and small group segments here in Connecticut. 88 years speaks for itself. We're not going anywhere. We've been here since the beginning, essentially. So remain fully committed. It is a difficult, obviously, marketplace to operate in, but we are fully committed long term. We're trying to become more sustainable. I mentioned that at the outset of my comments. We are fully focused on provider negotiations. They do become more and more difficult. Some of my counterparts over here stress the importance of price and how hospitals are impacting that. So it is a big focus of ours. We do, as I mentioned earlier, still have full participation of all the hospitals here in Connecticut. Difficult negotiations are always ongoing, but we still consider them a great partner of ours, and we just need to work better together to make sure that we can sustain this long term.
Thank you. And my second question is, again, for all three, but we will begin at the other end of the table with Anthem. As Dr. Gifford noted, all across this administration, across agencies, we continue to have discussions on the cost of healthcare and the cost drivers of healthcare. And we do this because we are serious and not only wanting to identify the drivers, but also to help facilitate solutions that may slow down or decrease the current increase in the cost of healthcare and thus of health insurance premiums. What initiatives have you as an organization undertaken that you believe have been successful at slowing or decreasing costs as you look back? And at the flip side of that, what is the most significant obstacle you face when you're trying to facilitate solutions? And again, we'll begin at the center of the table.
Yeah, and I mentioned this earlier as well. The move from volume to value has been our most significant initiative that we've had over the course of the last several years. Our enhanced personal health care program, as I mentioned, has, I threw out some statistics earlier, really taken off. We don't want to just pay providers for the service. We need to pay them for outcomes. It all needs to be value-based in order for this to be sustainable long-term. Without that, the system completely falls flat. So on top of that, member engagement has been everything for us. We've invested a ton in technology and making sure that members are fully aware and educated about what their options are. All of our disease management programs, our chronic care condition programs that we have, our mobile app, Sydney, now can provide access to real-time doctors via text and web interaction, which is something we never saw if you go back 5, 10, 15 years ago. So all of those types of things that we're looking at, further expansions with other partnerships, other vendors that we're looking at. There's a big focus from OHS on primary care physician utilization, I know. We did just recently enter into an arrangement or partnership with a company called Apri Healthcare or Vera Whole Health. So we are in the process of launching a primary care facility in the Farmington area in the next month or so, which will just expand access to care via primary care, which also has a subset of accessibility through the Sydney mobile health app, like I mentioned before.
Thanks for the opportunity to be here. Commissioner, my name is Matthew Flood. I'm the Vice President of Network for United Healthcare. I would say, I'll start off with one of the kind of challenges and obstacles to affordability. I would say the consolidation of the provider network in Connecticut has been challenging, and specifically because I think we're struggling with limited access just in general across our entire population of providers in the state of Connecticut. We could always use more primary care, for example. And with the consolidation of the healthcare systems, if there's a trend request, for example, that we are not able to meet, it does present a larger access risk than maybe in the past, where one system coming out of network really will not only not provide, will limit the access of the residents of Connecticut and our members, but also cause a business risk, customer loss. You really have to have every provider within the network in Connecticut. I think just baseline, we do have every provider in the state of Connecticut in our network effectively, but it's the challenge of that consolidation and the risk of losing one system, I think, puts a lot of pressure on that. I would say some of the opportunities, again, just to kind of repeat what was said, we have a real concerted effort to be moving from volume to value. We're pushing hard on including performance-based measures in all of our agreements, continuing to kind of progress down the total cost of care road with our accountable care organization relationships. And then just making sure that we're giving our members the information that they need to make cost-effective purchasing decisions for, services like imaging or ambulatory surgery, where they can find the lowest cost and high quality locations. So just some commentary on those two things. Thank you.
Thank you, Matthew. And before we move on, I just want to follow up with one item you raised. Essentially, if I heard you correctly, what you said was that as you go forward in Connecticut, you pretty much have to have every provider, every group within your network. Otherwise, there's a significant business risk. But looking at it from the other side, it would seem to me that that also gives a veto to the highest cost provider, because you cannot afford to lose them. Is that accurate? And if it is so, what measures are you taking or attempting to take in order to address that?
Yeah, thank you for the question. It does strengthen that veto greatly, because with the larger amount of providers consolidated to one area, losing them is a risk to access and a risk competitively, right? Where customers will leave us to go to a network that contains 100% of the providers. I would say my personal approach in managing the Connecticut network and then broadly across New England is to make sure that I'm out in the provider community building as strategic of a relationship as I can, understanding the strategy, understanding the challenges that are being faced by our provider community, and making sure that as we're negotiating our agreements and even preparing even a year or two out in advance, I'm making sure that I understand where those pain points are and collaborating with them to develop solutions that aren't just throwing money at the problem. It could be working to operate as administratively effectively as possible through electronic connectivity, or just as an example. So, and then again, really trying to find a model that both we and our members and the providers can live with and thrive with it in terms of a performance model. And we're doing that, as I mentioned, in all of our negotiations. So yeah, that's the answer to that question. Thank you, sir.
Thank you. Medicare?
Commissioner Mays, to your last point, we do have a relatively new value network. So we are trying to develop a more narrow network where we don't have to have all the hospital systems in that network. Now, that's going to be a long-term strategy, because right now the price point's not where we want it to be. But we're going to continue to try and improve that program over time. And we think it can be successful over time. But again, it's not a short-term fix. We also are doing much on the value-based contract area, where we're trying to pay based on quality and not just based on quantity. So we're doing some of the things that our competitors here are doing.
Thank you. Those are my questions. And next, I am going to turn it over to Assistant Deputy Commissioner, Chief Actuary, and Head of our Data Science Division, Wanchin Chu. Wanchin.
Thank you, Commissioner. Hi, good morning. I'm Wanchin Chu, the Chief Actuary, Assistant Deputy Commissioner for the department. Join us today. We have two of our health actuary with us, and both of them are experienced. And Tricia has been doing this rate filing for several years, and Sarah has now very involved in this too. And for the company reviews, Tricia is mostly for the Anthem, and Sarah this year has been spent a lot of time with the United and the Connecticut. And as our commissioner mentioned about is our rating authority is we evaluate the rate requests to make sure they are not be excessive, inadequate, or unfairly discriminatory. And also in addition to that count, in order to achieve the counter review process, we definitely consider all the historical and projected experience, the medical and pharmacy trend retention assumption, and many of the state and federal mandate and some of the change assumption and other actuarial factor. Significantly, the CID's actual review of all rate filing are all combined with all standard of the practice from the actuary standard, especially for ASAP 41 for communication and documentation, ASAP 23 for data quality, ASAP 25 for credibility, and ASAP 13 for treatment procedure. And we also definitely thank you, Dr. Guilford. We also consider the cost growth benchmark very carefully and then compare, and they also complete a very thorough peer review process in order to do that. And the last, before I pass it on to Tricia and Sarah to ask questions, I'd like to say thank you to all the company participating in this effort for the rate filing, for your timely response, and also very professional documentation with us. With that, I would like to ask Tricia and Sarah to go ahead and ask some technical discussion question. Tricia.
Thank you, Wen-Chin. Good morning. I'm Tricia DeVay, one of the actuaries performing the rate review of the Affordable Care Act health filings for 2025. We're going to ask each carrier here today a set of questions and finish with that carrier first before we move on. I'll start with Anthem. Please note, Anthem has submitted rates for both individual and small group. So I will note in the question if we're looking for an answer for both or for each individually or just one. First question, you requested an average increase of 9% for individual and 13.6% for small group as mentioned earlier. Just to recap, could you please provide a summary of the major components contributing to that request for individual and small group?
For individual, the average rate increase is 9%. Some of the key components that driving the rate increases are the medical trend, which is roughly 9 to 10%. The risk adjustments, which is it's a drop compared to historically that we receive, driving another like 4% increase. And then the drug rebates, it's increasing, that driving down the rates. And then there are favorable experience that we see in 2024. It's also driving down the rates roughly like 3.5%. On the small group side, the average rate increase is 13.6%. The medical trend is around 9 to 10%. And then again, the risk adjustments, since it is dropped compared to the past, it's driving up the rate increase by roughly 4%. And then the drug rebates, very similar to individual, it's driving down the rates by 1.4%. And then on the opposite end of the emerging experience, we see higher trend on the small group side. So we anticipate that 2024 is going to be an unfavorable kind of emerging experience that driving up the rate increases by 1.6%.
Thank you. And we're going to be touching on many of those items this morning. Regarding COVID, you didn't mention as a major component, but this has been a significant subject. In the past years, there has been a COVID adjustment that overall decreased rates. This adjustment reflected the decreased level of claims in the projection year versus the experience year. In other words, costs were decreasing. Please explain any adjustments for experience year for COVID this year to better reflect projected 2025 experience, including the cost of vaccines, testing, and treatment, and detail any differences for individual versus small group.
So for the COVID, because we are using the 2023 base experience, 2023, we are pretty much almost out of the COVID kind of experience. So when we're projecting into 2025, there is minimal impact due to COVID. Obviously, lately, we heard there's a lot of like spread out there. So anything going on right now is not factored into our rates development. So what we built into our rates are very small, and pretty much now we treated COVID as if it is a flu.
Okay, thank you. So just to clarify, there's no adjustment up or down. And we're not saying there's no COVID costs. It's just the change is going to be negligible between the experience year and the projection year.
That is
Is that correct?
That's correct.
So we're kind of in a steady state. Okay, thank you. Also, state mandates were not mentioned. Can you provide an impact on pricing for the 25 rates for any state mandates not included or partially included in the 2023 experience year, and any state mandates passed in the most recent legislative session?
So for mandates that passed prior to 2024, the majority of those mandates are already in our experience. So we don't have to build that on top of the experience that is already reflected there. The mandate that passed in 2024, which is, I believe, 3 mandates that was passed. Due to the timing of the mandates, that is always a challenge when the mandate pass, and then we have to submit the rate filings in early June. So we don't have a lot of time to evaluate what the impacts in the mandates. So we didn't have the chance to build in the cost for that yet.
Okay, so again, just to recap, similar to the COVID, it's not that the mandates that are in the 2023 experience are zero. It's the mandate's already built into the claim. So when you're projecting for 25, you're just expecting at the same level.
That's exactly right.
Okay, thank you. Regarding prescription rebates, confirm if pharmacy rebates are reflected in your pricing for 2025 rates, and specifically how you determined your projected rebate for the 2025 pricing.
The answer is yes, we do reflect that in our pricing. The way that we forecast the rebates was we start out with the 2023 actual rebates. And then what we did was we apply a trend assumption to forecast into 2025. For individual, the amounts that reflect in the rates are roughly $53 PMPM. And then for the small groups, it's roughly $58 PMPM.
Okay, so I'm just confirming it is in your pricing, and it is working to reduce the rates when you bring those in. And in the last 3 years, the rebates appeared to increase at a level greater than your overall trend. You stated in your filing that your prescription trend is considerably higher than the medical trend. Why do you project the rebates forward at an overall trend and not say a pharmacy trend if they continue to come in higher than forecasted?
So in terms of historically how it coming up, I think there's 1 year that it's a one-time change. So that's why you see a big increase. We use the average trend assumption because that's what we have. I mean, you can argue that we can use the different assumptions that we have there. So for that, I mean, you could easily use like the drug trend, but I think over time, the rebate probably will reverse to the regular trend.
Okay, thanks. Regarding trend, which is the most significant component, for small group, you're projecting a trend of 9.6%. On individual, it's 9.8%.
That's correct.
Yes. What are the largest drivers of your trend?
There are three components to the medical trend. The first one would be the unit cost trend. The second one would be the utilization trend. And then the third one, you always have like new technologies coming in, specialty drugs, particularly where you have a change in the mix of the services that driving up the trend.
Okay, and do you have any comments? I know you commented on utilization, unit costs. How about by service category, the professional versus the inpatient, outpatient?
When we develop our trend, we don't go down to that level. So what we did was we start out with an overall services for medical and then for pharmacies. And then what we did was we remove all the noises. Like, for example, COVID is a perfect example where we moved that noise, aging, work days or something like that before. And then after that, we would use regression models to project out into the future years. That's how we develop our trend. We do not develop our trend down to different service categories.
Okay, so I did notice for both your small group and individual, when you look at your experience trend on the allowed basis, it ranged somewhere from 8 to 10%. And for both markets, these historical trends were the result of high unit costs, averaging around the low teens, and negative or low utilization rates. What is causing this, and do you expect this to continue in your projected trend?
The utilization is a very challenging one because you always have the mixed issues as I described earlier. You can easily see an increase in utilization on, let's say, PCP or specialist. It's not the same level of service as if you have an inpatient or outpatient, and as well as the drug.
Oh. Arthur, are you getting tested? Why doesn't need to get tested? Audrey, cover.
Please go on mute if you're online. Thank you.
Okay, you had mentioned that you do not break down your projected trend into different categories by service category, utilization, unit cost. Could you then walk us through your process for determining your future trend and how much you would rely on historical trend versus the addition of any other factors not reflected in your past experience?
So as I described earlier, we start out with the allowed trend TM. And then we would remove some of the noises as I described earlier. And then we use a regression models where we look at the historical data and then the regression model would forecast it out, what that numbers would be. And then we would add on top of that leveraging factors to take from the allowed trend to a pay trend.
All right, and then the pharmacy trend just continues to outpace the medical trend historically. Can you just remind us what you think is driving this? And does Anthem have any thoughts or tools that have worked to help reduce this going forward?
For the drug trend, I think Brandon mentioned about the utilization management limitations that we have. AWP, average wholesale price. Specialty drug definitely is one of major driver of the cost, and then brand name drugs.
Okay, the Office of Health Strategy determined a cost benchmark of 4% for 2024. your projection is closer to the 10% range for both the markets. Why such a large difference?
So when we develop our trend, we are based on the individual's experience to develop the trend. The same thing with a small group. We have to use a small group experience to develop our trend. And we have to follow our actuarial practice where the trend assumption have to be reasonable in relation of to the increase in the cost. So the 4% trend, which is it's outside of the range. So we have to use a trend assumption of roughly 9 to 10%, which is based on our historical data with the forecast going forward.
And if you look at just the Anthem experience by itself, it looks like the currently approved trend rate, your projected trend rate are fairly level. Do you see this as being level for everything going forward, or do you think there is a mix or some things are working to get the cost down and maybe being overshadowed by some things where the costs continue to increase up, or which way do you see it going?
We continue to see a similar trend as we see in the past. As you quoted earlier, it was roughly between like 9 or 10%. We anticipate a similar trend going forward.
Okay, and then regarding the 2022 minimum loss ratio report put out by CMS and the federal government, they listed a $6.7 million rebate that you were required to pay out for the small group block for your company. And this is the 2022 report. You have estimated a 7.2 million amount for the 2023 minimum loss ratio. Can you provide an explanation of these figures and state if they and how are reflected in this filing, why or why not?
Sure. The MOR calculation is more like a historical kind of calculation where you go back in time and you calculate the average of the 3 years. If carriers are missing assumption in their pricing and the MOR are running below the average, running below the 80%, and then carriers are required to pay back the rebates. In our rate filings, when we use 2023 experience, any favorable experience that you see for 2023 is already reflected that in our rate filings. And then we take the 2023 experience, we forecast into 2025. That's how we come up with our 2025 rates.
Okay, thank you. And then regarding the risk adjustment program, Anthem has historically been a receiver within this program for the individual market. In 2023, Anthem was actually a payer. What changed, and do you project that Anthem will be a receiver or a payer in 2025, and why?
So in our initial rate filings, we actually did not make an attempt to forecast into 2025. Based on historical guidance from the department, carriers are asked to reflect the base experience kind of risk adjustments. So when we did our rate filings, we actually thought that based on our estimates, we thought that we're going to be a receiver for 2023, but it turned out the actual results we was the payer for 2023. And on the small group side, we still a receiver, but it's a big drop compared to 2022.
Okay, and I just want to clarify for those here, if you switch from being a payer to receiver, this would result in a decrease in rates. Is that correct? I think so.
No, actually,
No,
it's going
increase.
to be an increase in rates, because if we receiver and then we would reflect in the rates, so it's going to be a reduction in the rates. However, in this situation for individual, we are payer, so it's going to be a increase in the rates. You can argue that should we reflect the risk adjustment for the base experience period or projected into 2025? That's another argument that we can ask. Should we reflect in our rates what we forecasted, or should we use in the base experience?
Okay, and just to clarify, the department has traditionally looked at the most recent information that comes out from CMS. We usually we look at a PM basis and project that going forward, mostly because that's our best estimate what's going to happen in the future. But certainly we are open to people's coming on arguments on why they think the market may or may not change. We may choose to stick with the current path, but we're always open if there's been a huge change in the market. That concludes my questions today. I'm going to pass it over to Sarah Moo, and she can finish the questions. Thank you, too.
I'm Sarah Moo, the House Actuary at CID. I'm the reviewer of the 2025 rate filing from United Health and Connecticut. I have a few questions for each carrier, and I will start with United. Michael, can you hear us okay? The first question for United Health is that you requested an average rate increase of 8.9% for Oxford Health Insurance, 5.1% for Oxford Health Plans, 9.0% for United Health Insurance. Please provide a summary of the major components contributing to the request.
Yep, thank you, Sarah. The biggest driver is really our baseline experience and updating our 22 experience to 23 experience. What we saw in 2023 was an increase in claim costs of about 8.9% compared to our 2022 calendar year after adjusting for catastrophic claims. That is the biggest impact, and you can see by our rate requests that they are very similar to the 8.9% claim increase that we saw. Another item is that trend is currently projected at 9.5%. Last year, we filed a trend of 9.3%, but were approved at 8.3%. The increase in the trend from the approved 8.3% to the 9.5% also does have an impact on our rates. There are a few additional items that actually decrease the need for a rate increase. One is that we reduced our risk target from 3.2% down to 2.8% for 2025. We also reduced our selling expenses from 3% down to 2.5% for 2025. And we reduced our general administrative expenses from 7.8% to 7% for 2025. So all of those reductions will help members see lower rates than what they would have been otherwise. And then as far as the differences between the three licenses, that's really driven by benefit changes. So OHP had further benefit reductions, while OHI and UHIC both had benefit increases. And if you exclude the benefit change piece, all three would be at 8.6%.
Thank you. The second question is, please explain any expected changes to morbidity between the experience period of 2023 and the pricing period of 2025 due to the changes in the small group market, such as the exit of Cigna.
Yeah, thank you, Sarah. We do not apply any morbidity adjustment to our rates for 2025. We do believe that there is going to be some shift due to Cigna exiting the market. Obviously, they have a pretty significant block size, and that does increase the risk that insurers take on. So the one reason why we decide not to take a morbidity adjustment for that is that if those claim costs tend to be higher or lower than our block, it should be offset by risk adjustment. So we do not make any adjustments for that at this time. And we do not make any morbidity adjustments for other reasons as well.
Thank you. The third question is regarding risk adjustment. The risk adjustment transfer for 2023 benefit year released by CMS shows that United and Oxford, all three legal entities combined, is paying to the risk pool for 2.2 million or $8 PMPM. What is expected change of the risk adjustment amount from 2023 to 2025 for your companies? Please explain your process in projecting the risk adjustment for 2025.
Thank you, Sarah. Again, we do not make any adjustments for 2025. We assume that on a percent of overall premium, we will pay the same amount in 2025 as we did in 2023. The reasoning behind that is that if you see significant changes in your claims in 2025, that would really drive the risk adjustment piece. So if we do see an increase in claims, we'll see that claim number rise, but we will also see an offset on risk adjustment where that would decrease. And same vice versa. If claims were to fall, we would likely become a bigger risk adjustment payer. So when we do develop our pricing for 2025, we really assume that we'll be paying the same amount on a percent premium as we did in 2023. And any offsets of that would be offset by the claim cost projection that we're projecting in 2025.
I have a quick follow-up question on your answer. So when you're speaking of the percentage of premium, were you speaking of the premium of the company or the state average premium?
We use the percent of our premium as kind of the indicator, but the driver of the overall number is the statewide premium. So as long as we assume that the statewide average rate increase is the same as our rate increase, that would be correct. When we file, we don't know what other carriers are filing, so we feel that that is the most appropriate answer. However, as turned out, Anthem actually is seeing a larger statewide increase based on their request, so that number would change slightly. The overall impact tends to be pretty small in those cases, but it does have some impact.
Thank you. The next few questions are concerning your pricing trend. Your pricing trend is filed at 9.5% for three legal entities combined. First question, please explain your process in determining the future trend, including your reliance on historical trend experience, the emerging experience in 2024, and any additional considerations.
Yeah, thank you, Sarah. First off, I just want to mention that we do have a different team, a HCE team that does handle our trends. They really are the trend experts on our team. I can speak to it high level, but I do not have the expertise that they do as they develop the trends. My understanding is that trends are developed both looking at historical data as well as emerging experience. When we look at trends as far as utilization, they use historical utilization to determine what we expect utilization to be going forward. They also look at upcoming provider contracts and use that in developing the unit cost piece of the trend. So there's multiple pieces that go into it. Again, I'm definitely not the expert on our team in this. We do have a separate team that handles trend. And if there's any like really specific questions, we'd be happy to follow up after discussions with him.
Thank you. The second part of the question, the proposed pricing trend of 9.5% includes 4% utilization and service mix trend. Please explain the main drivers of the 4% utilization and service mix trend by type of service.
Yeah, thank you, Sarah. There are quite a few different categories that have really stuck out to us as drivers of increased utilization. One of the biggest ones is behavioral health and the capitation that we pay on that. I think everyone's aware that since 2020, behavioral health costs have been on the rise. We've also seen an increase on outpatient surgery. The big drivers there, from what I've been told, is colonoscopies. There's kind of a push to lower the age limit of when people get colonoscopies, and that drives some of that. There's also been a lot of hip and knee injuries in 2023 that we've seen. So that's another big driver on the outpatient surgery side. And then a few things on the RX side, the pharmacy side, which has been pretty high in recent years. One is infusions. Gene therapies are driving the cost of that. Skin mucous membrane agents. There's a few drugs that are really driving that category, which I'll probably pronounce incorrectly, but Skyrizi and Dupixent are two that have been called out to me. And then the last item is GLP-1s and weight loss drugs. I think there's been a lot of news about them recently, and we have seen an increase in utilization in those drugs as well.
Thank you. The third question continues on the pharmacy trend. As we are all aware, the pharmacy trend continues to outpace medical trend historically and going forward. What is driving your projection on pharmacy trend, and what has your company been doing to reduce this going forward?
Yeah, thank you, Sarah. Again, some of those items that I mentioned earlier, I think are big drivers. There's, I'm sure, more as well that we could expand the list as a follow-up. And then as far as what we're trying to, or what we're doing, obviously we have a lot of affordability programs that do focus on reduction of RX cost as well as utilization. They have been successful for the most part, but obviously those trends do remain high. Pharmacy drug costs are something that I think have been on the rise for many years. And I think that without some sort of regulation capping the price of them, that's going to be a challenge going forward as well.
Thank you. The last question concerns the cost of care initiatives the company has been taking. So in your pricing trend going forward, have you reflected any impact of the initiatives the company is taking or plan to take in the future years? Please comment on this from both unit cost and utilization perspective.
Yep. Thank you, Sarah. Again, I don't have numbers broken out between utilization and unit cost, but the amounts that we do see tend to be in the range of 2 or 3% in reduction to our annual trend, based on our initiatives that we take on affordability. So it does have a pretty significant impact to our members. It does help us keep our price down. And obviously it benefits both our members and us as well.
A quick follow-up question. I appreciate the quantitative measure you provided, the 2 to 3% impact by the initiatives. Is that a correct understanding to say that without the cost care initiatives, the trend you forecast going forward would be even higher by 2 to 3%?
Yes, that's correct. That's my understanding.
Thank you for your comprehensive response. Now I'm going to move on to the questions for Connecticut. The first question is regarding your request of 7.4% rate increase for Connecticut Benefit Inc., CBI. Please provide a summary of the major components contributing to this request.
Sure. So pricing trend is going to be the biggest component of the rate request. Additionally, we have some baseline changes where experience that we're using to project is emerging differently. Additionally, some movement in what we call non-fee-for-service claims, things like rebates, capitation, et cetera, that are helping to lower the cost. Those are really the big components of the rate request.
Thank you, Brendan. The next question is please explain any changes to the morbidity between the experience period of 2023 and the pricing period of 2025 due to Medicare redetermination or unwinding, and impact on rates for both CBI and also CICI.
So we have a very small factor of 0.3% for Medicaid redetermination. That did begin in 2023, and we're not expecting any net change in 25 relative to 24. However, because the baseline that we're using to trend forward to 2025 is the full year of 23, the full impact of that Medicaid redetermination is that we believe is the ultimate amount is not fully captured in a full year of 2023. So we do have a minor adjustment for that going to 2025, but absent any further changes, would not expect to need any sort of adjustment beyond that.
Thank you. The next few questions are concerning pricing trend. For CPI, you filed for 10.3% pricing trend. The first question is, please explain your process in determining the future trend, including your reliance on historical trend, the emerging experience in 2024, and any additional considerations.
Yeah, so we look at a number of different components of trend. For utilization, we tend to rely more on historical patterns and how much we've seen utilization increase year over year. As we're thinking about unit cost and how the cost will change, we take a look at contracting and where we are renegotiating with providers or have changes in our contracts to pay a different amount for the same service in a future year. We are factoring that into the best knowledge that we have as we're filing our rates. There are additional components, things like service mix, provider mix, technology, leveraging as well, that are additional components that lead to those trends. But for each component, we tend to look at different information to give us the best information possible as we select a trend.
Thank you. The second question concerns your outpatient type of service. The outpatient trend has been running greater than inpatient and professional trend in the historical period. It is also projected to be greater than inpatient and professional trend going into 2025. What is driving this, and does Connecticut have any ideas on how to reduce this going forward?
Yeah, I think we're seeing utilization trend differently between inpatient and outpatient. We're actually seeing some negative utilization on inpatient, which are more costly services, which actually should be a good thing. So that is really the difference between inpatient and outpatient on the utilization side. Unit cost from a just cost per service perspective, we tend to see them trending in similar manner. But we also, as some of the others have highlighted, things like outpatient surgeries, we have really been seeing a lot of increase in outpatient surgery as well as infusions. Those are big items for us that are driving the outpatient trend up.
Are there any initiatives the company is taking to contain the outpatient trend?
So I would say the initiatives we have, we look at each type of service, and I'll use outpatient infusion as an example of where those services are taking place, and could we do something like a site of service initiative to perhaps encourage a member to get the same service at a cheaper location. Things like that, and recontracting are types of initiatives that we're looking at to try to lower those costs.
Thank you. Pharmacy trend continues to trend significantly over medical trend in the past and going forward. What is the company doing to reduce this going forward?
Yeah, so pharmacy is definitely a challenge for us, as it is for, sounds like, all other plans as well. Really where we're seeing the pressure is in brand and specialty drugs, as there are no generic alternatives for those drugs and the cost of those drugs continue to rise. Additionally, GLP-1s are an area where members appropriately are taking GLP-1 drugs for diabetes. Those drugs tend to be much more costly than non-GLP-1 drugs. And so we are seeing some continued pressure there. We work with our PBM regularly to try to get better rebates, better discounts off the price of those drugs. So that is something that we actively work on to try to mitigate those costs. As it relates to rebates, we also make sure that all the rebates that we are receiving, we are passing through in our rates, and the members are getting the benefit of those rebates as well. So we are trying to actively mitigate those costs, but the rising costs of those drugs where there aren't necessarily alternatives for members to take that are cheaper is continuing to put pressure on the pharmacy trend.
Thank you. The last question. The total pricing trend, which is 10.3%, it is greater than the cost benchmark of 4.0 for 2024, determined by the Office of Health Strategy. Have you reflected any impact of the initiatives your company is taking in the pricing trend projection? Please comment on this from both unit cost and utilization perspective.
Sure. So we have initiatives in place, things like managing hospital readmissions and payment integrity items, looking at our high cost members and really trying to assess what opportunities there are. Those are things that we do today, and those are things that we also will do in 2025. So as it relates to our rate increase, we did not make any specific adjustment for those items, because while we do them today and do them in the future, and they are generating savings for us, there's not necessarily a change in the value of those savings going from 23 to 25.
Thank you, Brandon. That concludes my question.
Okay. Thank you, Tricia and Sarah. I have all these kind of question and answer from the company. Thank you so much for that. And so before I ask any additional question, do we have others question?
Wanchen, well, if you have a question, please go ahead.
Okay. Let me just follow up on the question itself. I heard from a lot of you, and then also when Tricia and Sarah asking about the cost benchmark, 4%, and then your annual trend. From here, I see is kind of Anson has 9.6% or 9.8% annual trend, and United has the 9.5%, and then Connecticut has 10.3%. And earlier, I quote on this kind of trend, ASAP itself, 13, and then also credibility. So compare yours with the cost benchmark layer. I think you probably need to discuss more in addition to the cost contamination you are working on. And so when you compare yours with the utilization, with the unit cost about the trend itself, in addition to say your company's experience show you deserve a higher annual trend, have you considered any kind of credibility subject? Because compare among the different company, it seems to show a little bit different, and compare yours with the cost benchmark also show the difference. Thank you. Okay, why not start from answer?
As I stated earlier, I'm pretty sure Tricia and Sarah have to follow the similar actuarial standard practice. The growth benchmark, I believe it was developed based on the median income and also based on the state gross domestic products. Versus the trend assumption that we are using, we are based on the experience of the individual. If we develop rates for individual, for small group, we would develop trend assumption based on the small group's experience. So based on the actuarial standard practice, the assumption has to be reasonable compared to the cost. So based on the experience, we do believe the trend assumption that we use in the rate filings is a lot more reasonable compared to what the benchmark shows. So that's how we come up with the pricing trend assumption.
Okay, thank you too on that.
Mike, could you speak to that, please?
Yep. The one thing I would state is that with credibility, the more years you look back, the more credible your data is going to be. We did take a look all the way back to 2019, and we saw that claim costs have increased by about 8% annually. So obviously there is a lot of credibility there. We also have looked at various studies. There was a recent PwC study that stated that trends are going to likely be higher than they've been in the past 13 years in 2025. So there's obviously a lot of credibility in studies like that as well. I would also add that when we do trends, our team looks at local data, but also looks at nationwide data. And clearly, like with the size of United Healthcare, it's very credible that way as well. So we do feel that our trends are accurate. I think when we look at where we were last year with our projection compared to where we came in with claim costs, it was very close. And as Anthem mentioned, the benchmark was kind of developed not using actual claim costs, but rather data that is kind of external of what claim costs actually are. So we do feel that our process is credible and correct.
Thank you, Mike. Brandon?
So I would respond very similar to United as well. Our membership in the state of Connecticut in the individual market is over 75,000. I would view that as credible. We look at many years of data. So additionally, we went all the way back to 2019, pre-pandemic, try to assess how have costs really changed over the last 5+ years. We have additional components of trend, as I mentioned previously, utilization, unit cost. We're cognizant of the benchmark, but as we're projecting trend, we feel it is appropriate to look at what we have seen in the market and how things have trended specifically in the Connecticut individual market as we are selecting a trend to project forward.
Thank you, Brandon.
I'm going to ask a question for all three of you again, following up on that. I'm not an actuary, so I don't know how to do the fancy numbers and all that. But I am looking, and I think consumers are looking at the fact that we're looking to cap the cost growth at 4%. We're looking at this, to many of us, nebulous idea of trend. And on average, it seems to be about 10%. And what I'm hearing is essentially that this is being determined by the past. But if we're looking to cap growth going forward, the past becomes prologue. And what the rates going forward should reflect the efforts that we are making now. What am I missing here? I mean, is there a reason that the cost growth benchmarks and other efforts are not reducing the trend, and that you're completely reliant on what has happened before the benchmarks and other measures were instituted? And we'll start over here.
Yeah, I mean, I think the hospital negotiations have become more and more difficult. That's a big factor. Pharmaceutical costs rising is another one. So, I think when we were here last year, we talked about having the hospitals and the provider systems in-house. I don't see them here today, so I would love to hear from them at some point, probably as we look forward into the future. We are implementing all types of new strategies to drive down the overall cost of care. I mentioned our chronic condition programs, disease management programs, population health programs, the investments in technology. You can throw so many different things that we're doing to drive that cost down, but the unit cost still continues to be an issue. So I think until we address that very specifically and head on, we're still going to be in the same place looking at trend in the future at the same rate.
Thank you. I would say that part of the evolution of healthcare expenses also comes from improvements in technology and better healthcare outcomes, but it comes at a cost. So that cost does get involved in the process. Additionally, utilization varies year over year. We saw for a long time, a lot of care was taking in the hospital setting. Now it's an outpatient setting. We can expect that to continue to evolve. We do see a lot of price variability in the environment, whether it belongs to radiology-based benefits or others. And as I mentioned earlier, we really want members to become more educated to understand that there are choices when they're making healthcare decisions, and that costs can vary and have it be equal to or better outcomes. So that's part of it as well. But also, I think one of the biggest reasons that benchmarks can be difficult is we need the hospitals involved in these conversations as well.
Yeah, and that was the subject of my opening statement. We do have a problem with hospital systems consolidation. The benchmarks are very helpful. We use those every single day when we're negotiating, but they, of course, talk about other things like inflation, and they have significant market power. So things like, getting rid of contract clauses that require neutrality, revenue neutrality clauses, things like that can actually help us kind of rebalance the bargaining power with the parties.
One follow-up question, because I think everybody mentioned hospital care costs. Could you let us know, on average, as you've been looking at renewing these contracts with hospitals, how much the increase has been? I'll begin with Connecticut.
Yeah, I don't think we have the average hospital increase with us today.
Well, could you give me an idea of the range then?
Well, I mean, if you're asking about what they're asking, I mean, we can have some hospital system asking for double-digit increases. Of course, we're not agreeing to those. And we have other hospital systems that are being more reasonable. So it's really arranged.
Thank you. Let me move to United.
Yeah, I would say there's a wide variance in where the negotiations are shaking out. I would say I recently had a request for, an increase from a system in Connecticut that was 5 times the 2024 Office of Healthcare Strategy cap. It's not, there's another one that's about 2.5 times the 2024 cap. Back last year, a request for triple the cap from another system that we just couldn't lose. So I would say that, and again, to the points made here, it's really driven by staffing costs and inflation from the hospital's perspective. And so we get into a much more aggressive negotiation posture to try to end up landing these renewals at an acceptable trend. But the asks are consistently high single digits, low double digits right now. And I would say the hospital, I don't have specific hospital trends for 2024. I would say that the hospital trends are higher than the physician trends in terms of where these negotiations are landing at this point. And so the overall total cost unit price trends are being somewhat mitigated by the physician increases in terms of a unit price, but the hospitals are driving it currently. I also would say acquisition activity in the market is moving physicians to a oftentimes as a required and consolidated with, private equity backed firms, for example, that are acquiring groups in the state. Those are also contributing to a significant increase in physician costs at this point.
Well, I'm going to move to Anthem for an answer, but I would love to hear if you could expand a bit on private equity. We've all heard the concerns about private equity ownership, consolidation, cost increases. Are you seeing this in the Connecticut market? What impact is it having?
I am seeing that to some extent. There's been a couple of recent acquisitions in the state of Connecticut. I prefer not to name names in this form if that's okay, but these acquisitions did have one in particular had the effect of taking a group that we've been working with for many, many years, having kind of reasonable cost of living type increases in our renewals, and coming out with a double or triple demand. And so, we had a little bit of risk in that renewal. We ended up getting it done at a much higher trend, again, above the guidelines that OHS has put forward. But again, very important primary care focus group that we needed to keep in our network and make sure that our members had access. So that is and there's 2 or 3 happening in the state or happened in the state that I think will drive up costs ultimately.
Thank you. Anthem?
Similar response for Anthem. We are seeing increased requests all over the map. So really it does vary by provider. But what I will say is that, the engagement that we've had with our hospital systems has been moving in a positive direction. So I don't want to make it all doom and gloom. The move from volume to value is real. And we have seen the fruits come out of some of that activity in the negotiation process. So where I think the conversations were 3, 5, 7 years ago, they're not nearly as close to that anymore. So we are seeing a move towards progress, but I think it is, a slow and steady approach.
Thank you. And now let me turn it over to the Assistant Deputy Commissioner and Chief of the Life and Health Division, Paul Lombardo. Paul?
Thanks, Commissioner. Good morning, everybody. Dr. Gifford mentioned in her OHS benchmark presentation that based upon the information and the data that they have, this is primarily a price issue for the carriers not being able to meet the cost growth benchmark on an annual basis. I just want to confirm price is not your health insurance premium, but price is the reimbursement that you are paying hospitals and providers and prescription drug companies. Correct? I need a correct from each of you. So I'll start with Connecticut.
That's correct.
Okay, thanks.
That's absolutely correct.
Okay.
December.
Okay, thanks. I just wanted to make sure everyone understood what that means because price can mean different things, but I think we all know here what price means. One of the questions, and Mark, you brought it up twice so far, the revenue neutrality issue in your contracts. Can you, in like 1 minute, briefly explain what that is? Because I look at when you contract with a hospital, you set their reimbursement at a certain level, whether it's based off of Medicare or based off of some other criteria. I thought you indicated that revenue neutrality says that if there is a development where you're able to save money within the contract, that you have to return that savings to the hospital so that your contract, it appears that you've said that you can never save money within your contract. And I believe your contracts are multiple years, correct?
That's right.
Okay, so go ahead.
Yeah, so, there are certain things we can do to try and reduce the cost of care. So payment policies, facility fees. We don't pay facility fees, for example. And so if we can go in and create new programs to reduce the cost of care through smart procedures, there are some contracts out there that will say from the hospital, you've affected my revenue. You've decreased my revenue. So now you got to make it up in some other way. You got to pay us back for those cost savings. So, we've done a lot in Connecticut to get rid of some of the more difficult and anti-competitive clauses, but that's one that we should also focus on.
Okay. Real quick, if you could estimate what you think that would be worth range-wise, if that were removed from contracts?
Yeah, we'll have to do a little
Okay.
math for that, but we'll get back to you.
Okay, great. And of the contracts you have with all of your hospitals in the state, what percentage of your total dollars are linked to these?
Yeah, we'll provide that too, but
Yeah.
It's the larger ones that have these provisions.
Okay. I'd like to ask the two other carriers, United and Connecticut, if you have similar revenue neutrality features in your contracts, if you're aware. Start with United.
We have been asked to provide, what I would call, I think revenue neutrality is a fine term, which is basically if we implement a cost savings policy, that'll be made up in the totality of the agreement. The other piece that I think is important, as we talk about revenue neutrality, is the ability to send, a procedure, for example, a colonoscopy that can very well be done in a freestanding, high quality location for a fraction of the cost that it would be rendered at a hospital outpatient. There's certainly a lot of pressure on our renewals to keep that volume from being shifted to those lower cost locations. And so that's always a challenge. It's something we work through, but it's just a dynamic that I think is very similar to the neutrality comment raised by Connecticut.
And Anthem?
Yeah, and I'll be honest, I'm not too familiar with the contracting piece myself, but we do have, shared savings programs in place, incentives for quality-based care outcomes and things like that. So I'm sure there's some element of that in there for us as well.
Great. What would be really appreciative is if you can identify features in your contracts that are limiting your ability to provide quality care and reduce the cost, not only to the members, but to the whole system. That would be extremely beneficial. I think everyone would want that here, not just the insurance department. I have another clarifying question. I think it was you mentioned the risk adjustment and paying and receiving and the flip-flopping. just so everyone knows, we have a significant increase in individual membership on the exchange through the Covered Connecticut program. So when you introduce significant volume to a system and you have two carriers, those carriers don't know exactly who they're going to get, and they don't know the actual risk that they're going to get. So there can be fluctuation from year to year in the risk adjustment. For obvious reasons in the small group market, Connecticut exited last year, Cigna is exiting for 2024, and Aetna to a certain degree. But that creates a lot of churning and moving of business, and it's extremely difficult to know the membership that you're going to get. That's a fallout from that. I think Michael mentioned, Cigna had a significant amount of small group membership. So that will be, where will those Cigna members go in 2025 in the small group commercial market will depend upon whether some of these carriers will have a effective change in their overall risk that would change the amount of the payment or the receipt, or actually flip flop it like Tu had mentioned. So I just wanted to get your feedback. I'll start with Anthem first.
I appreciate that questions, Paul. You are right. Whenever you have a significant change in the mix of memberships, it's drive uncertainties. Like 2023, when we thought that we would be a receiver, and then all of a sudden we are payer. 2023, that's when the Medicaid unwind happened. And then that continued in 2024. One thing that happened for 2024 and going forward, we see a significant change in our mix of memberships. For example, the Medicaid unwind, a lot of those members actually qualify for the cost share reduction, which is there are different benefit level under the silver medal level. The CSR 87 and CSR 94, that is the richest plan. Even it costs silver, but it's actually, it's richer than the platinum plan if it is on the 94% and 87. We receive a lot of memberships on those two CSR plans. So obviously when you're receiving a lot of members on those, it will change the forecast of what the risk adjustments going to be. Based on historical data, if you get a lot of those members, you're going to receive risk adjustment coming in the door. So even though we pay for 2023, we anticipate that we're going to, if not like net to zero break even for future years, or we anticipate it's going to be a receiver because of that new population coming in.
Thank you. Anything to add for United and Connecticut?
Yeah, thank you, Paul. I'll just add that I also appreciate the question. Cigna's block, we've kept a pretty close eye on. They were a pretty significant risk payer in recent years, and their claim costs haven't been all that low either. I think the one thing I would just ask that we all keep in mind is that as we look at 2025 and that this block, Cigna's block, is going to really shift everything within the market, to keep that in mind. Obviously, there's more risk going into 2025 because of this than in previous years. I think we do have a pretty low risk margin at 2.8%. We have seen loss ratios significantly change more significantly year to year than that 2.8%. So we just ask that you keep that in mind, that it is kind of an uncertain year, that they were a big risk payer, had high claim costs, and that if we're not careful and if we do see significant rate suppression, we may be seeing very large increases in future years if their block continues to perform how it has recently.
Thanks, Michael. Go ahead, Brandon.
Yeah, I would just add, similar to what was mentioned in one of the earlier questions, our approach to changes in population and risk adjustment and how they interact are if we do end up with a sicker population perhaps than we expect, we would then expect that the claim costs would be higher, but that also your risk adjustment, you'd either receive more or pay less. And they would typically offset each other such that it doesn't have a net impact on the rates that we're seeking.
Yeah, thanks for that, Brandon. That's an important point. I have one other quick question for Michael. Michael, from United, you mentioned that you saw an uptick in utilization for colonoscopies and the use of weight loss drugs. I would think that an increase in utilization of colonoscopies at some point down the road would actually be a benefit to the member and be a benefit to the health and actually potentially lower future healthcare costs. The same with the weight loss drugs, with the ability to potentially eliminate future morbidities that may end up having someone incur significant expenses in the system. So I just want to make sure that when you mention those specific bumps in utilization, that there's a potential for a savings to the system in the future. And what would you estimate that savings? When would that savings be incorporated, or when would you start to see it in your experience?
Yes, thank you. I do agree that we would expect to see savings from colonoscopies in the future. I think that sometimes those types of items are a little more long-term. I would just add that our trend team, I believe, does make adjustments to account for that. They also expect us to see improvements into the future. And I think I'll turn it over to Paul if he has any additional items. And then
Sorry, Mike, go ahead.
follow up if there's anything else.
Yeah, I'm sorry. Thank you. It's a great question. So that is the hope, right? That when we speak to GLP-1s, we're probably speaking more about the weight loss side. But as we know, there might be some benefits on the cardiovascular side as well as managing diabetes. We've also heard that perhaps over time, GLP-1 costs will go down. We do have a supply and manufacturing matter going on, if you will. The hope is that the costs will go down. It'll become more affordable. But one quick comment about the GLP-1 as an example is that weight loss management has been effective for some people and has not been effective for a lot of people as well. That is not a statistically proper comment in terms of whether it works or not. But what I will say is we have seen studies this year that have shown, as an example, current adherence to GLP-1s after 6 months is about 50%, and adherence after 12 months is about 20%. Haven't dug into it as much. I'm sure there's more data on that already, but examples of that might be people say, you know what, I really don't enjoy sticking myself with a needle. Somebody might say, well, I didn't see the effects I expected to get after 6 months, or there could be other practical clinical reasons, none of which I'm qualified to explain. But I will say that there's a lot of potential there. We're monitoring it. This is more than just a medication. It's also behavioral change. It's a lifestyle change. We look at it as a weight loss management environment when we're talking about that side of it. And we do believe there's a place for it, as long as it can also be affordable. So this technology advancement that's not affordable isn't really an advancement, but it's an opportunity, and we're looking at it very much right now.
Thanks.
Thank you, Paul. And I want to thank all the presenters here today. We do view it as a crucial component of this process for companies to clarify the rationales supporting the requested rate increases, not only for those of us at the table, but for the consumers who ultimately pay those rate increases. So thank you. We will be moving along. Our next session will involve questions from Assistant Attorney General Tom Ryan, followed by Dr. Gifford and the state's healthcare advocate, Sean King. But first, let's take a brief 10-minute break, and we will begin promptly at 11:25. Thank you. Please take your seats. We are about to resume. Welcome back, everyone. We will resume the meeting and we will move to the next part of the program, starting with questions from Assistant Attorney General Tom Ryan. Mr. Ryan?
Thank you, Commissioner Mays, and thank you to the Insurance Department for holding this forum, and thank you all for your attendance. I'm going to date myself a little bit here. I've been attending rate hearings since 2009. I think maybe Paul is smiling here because he may be the only other person in the room that has been around that long. But I have to say, since 2009, we've been hearing about unit cost trend, right? I mean, this is a recurring theme, and it seems to drive the basis of all the requested rate increases because it drives experience. And and I think it bears thinking about. We talk about unit cost, but and we call it medical cost, but really what it is negotiated medical cost. It's the amounts that your companies negotiate with the health plans, with the providers for the cost of care. So to the point made by the Attorney General in his letter to the Commissioner relating to these hearings, you guys are the only entities in the room other than the providers that negotiate these rates. Nobody else has any influence over that. You essentially do the bidding of your members and employers to try to hold down those costs. And historically, that hasn't worked. It hasn't worked. There have been, and we do hear from you that they're difficult negotiations, and it's you're up against consolidation, you're up against a lot of things. But since 2009, that has been a major factor in trend and in overall price increases. So, it's remarkable, I guess, under those circumstances that we haven't seen a change. Recently, well, actually not so recently, health insurers have been talking about value-based programs for negotiation, right? I mean, those things have been, I think, around I've been hearing about that for over 10 years now. And it really hasn't stopped the train when it comes to unit cost. And I guess I'd have to ask you guys why you think that's so. I mean, everybody talks about better outcomes and all those things, but why is it not holding down the actual cost of care?
Yeah, I'll jump in. We kind of talked about this a little bit before too, but it's not just unit cost per se. You have new technologies that are available. There's new kinds of drugs that are coming out on the market at all times. The overall inflation just in general that we're experiencing here in the United States and specifically here in Connecticut, I think are all other impacts and factors. So that's certainly a big piece of it. The drive towards value, I think, is still relatively new overall, where you're seeing providers start to buy into it and recognize that it's the way of the future. They were reluctant at first, and they still were fully reliant on, the reimbursement rate is the reimbursement rate. So I think we're getting to a point now where, again, those conversations are becoming very different than they have been in the past. And we are seeing some of that impact right now, but there's still a long way for us to go. The consolidation is still our biggest challenge. At the end of the day, when you're fighting against two major hospital systems in the state of Connecticut, your bargaining power is extremely weak at this point. So that's certainly what we're up against, at least on the Anthem side.
Yeah, if you guys answered to that too.
Yeah, thank you for the question. I would say that our renewals, our negotiations with our large systems, and we've talked about a lot of the influencers of that. We really look at each individual negotiation with a hospital or a hospital system or a larger physician group with a great degree of granularity. We look at all the publicly available financial information to see how that system has performed. That information is available on American Hospital Directory. It's posted online. We look at the relativity to Medicare. And we also look at how that relativity to Medicare is comparative across other hospitals in the state. I know Dr. Gifford, your slide, I'm sure we'll talk about that a little bit more, but we look at that information very closely. We look at the historical increases given to that provider for a matter of fairness. If they had not received an increase for a couple of cycles, we certainly build that into consideration in terms of the unit price trend that we put into that renewal. We look at competitive position through publicly available data and industry available data to make sure that the increases in the rates we're giving the provider are in line with the market. And we look at line by line details on every renewal around which areas are high volume and high cost, and we try to build mitigation strategies in our contracts to mitigate those items. And we
So
try to right size them at the
do you-
contract level.
Do you itemize in your negotiations? I know Connecticut said last year they do not, but do you actually look at each coded item to see, or do you negotiate on that basis ever?
We do.
You do?
I mean, but we certainly pick out certain services, or we'll bucket things into mammography or into MRI or into, certain categories of outpatient surgery. But yes, very, very granular code by code negotiations. So even if we've agreed to a percentage increase with a provider, we will go in and build the details behind the scenes to build up to a particular number if the negotiation has been done in a way where we have to agree to a number. And I would say that we try to reach the very sharpest number we possibly can without creating disruption in the market, disrupting our members, disrupting the residents of Connecticut. And we really feel like every one of these negotiations we hit, I feel like I can speak to the negotiations I lead and the role I have within United Healthcare. I never feel like there's any increases given out that are above and beyond the very sharpest number we're able to achieve in that negotiation based on the leverage of that system.
So you just had a contract dispute with Trinity.
Correct.
And in your on your website, you indicated that Trinity's request was more than double the Connecticut cost growth benchmark. That's a public-facing statement. How did you use the benchmark in your negotiations? How do you use it generally in negotiations? And I'd like to hear from everybody on this, but maybe United, you can start with it.
Yeah, I would say in general terms, maybe not specifically speaking to any particular system. I would say that some health systems in Connecticut have a greater degree of sensitivity to the benchmark, and others have a lower degree. In some instances, these negotiations are being influenced by entities that are outside of Connecticut. I would say that, so I would say it's a mixed bag, Attorney Ryan, in terms of how much, because I'll leverage it in every discussion. I will always bring up the benchmark, and some say, don't care, I want triple that, or
So you're
others
hearing
will.
that's irrelevant kind of thing?
In some instances, I will hear that it seems irrelevant. In other instances, without it being explicitly said, I feel there's a sensitivity to trying to manage within that number.
And these are nonprofit hospitals in Connecticut that are supposed to be serving their community. Is that right?
Correct.
Yeah.
Perhaps with the exception of Prospect Holdings, right? But
Right.
otherwise, yes.
Yep. To the topic of PBMs, all of your companies use PBMs, is that right? Is that
Yes.
true? Yeah. I mean, how do you know that those PBMs are negotiating the best prices for drugs? Do you audit them? How do you know what those drug prices are? Do they fluctuate during the year? Do you monitor that? What's your oversight, or do you just let them do what they do?
Yeah, for Anthem Elevance, Carolina RX is our PBM, which is a fully owned subsidiary of Elevance. So for us, we have a much bigger line of sight into the negotiation process, and we work directly with Carolina RX to provide that kind of feedback. So for us, it might be a little bit different than some of the other carriers here.
So do you report the terms of your arrangements in your filing with the insurance department, or, I mean, how do you, and how do you indicate your auditing function? I mean, how do you assess that?
Like I stated earlier, we have to base on the experience. So we start out, Carolina RX is already with us prior to 2023. So by using the experience for 2023, and then trend it to 2025, we already reflecting whatever the negotiation that Caroline did into our rates development and also the drug rebates.
So
We took the
But Anthem assumes that Carolyn is negotiating the best rates, or is there more oversight than that?
well, our rates, if you look at the individual rates and also the small groups, when I said rates, I'm talking about the
Yeah, I'm
premium
talking about
rates,
the
not,
cost of the
not-
drugs, actually. Yeah.
It's the lowest rates on the street. So I do assume that whatever the negotiations that we have, even though it's still a problems, it's the best that we have compared to the competitions that we have.
How do you pay them? Is it a capitated amount? What's the compensation to the PBMs? Is it based on per member per month? How do you pay for that? Or do you actually pay, do you just pay out for the drug costs with an administrative fee?
I don't know all the details, but it does whatever the drug cost that they negotiate on. And then some kind of fees. I don't know all the details on that. But whatever inexperience we for sure reflect in our rates development.
Yeah. United and Connecticut, could you tell us about your PBM arrangements?
Yeah, I can speak briefly to that. United Healthcare and Oxford Products in the small group in Connecticut utilizes Optum RX, which is another company within United Health Group. They're a separate entity. We actually have a PBM team at United Healthcare that communicates and interacts with Optum RX regarding both the PDL as well as the negotiation on the overall rates. We believe the contracts usually are on multiple years, but then separate to that, generally the negotiation isn't just for Connecticut, but it's also on a national basis with United Healthcare businesses, both small and large group.
Connecticut?
Yeah, so I'll try to answer as many of your points as I can. We also utilize a PBM, Express Scripts at Connecticut. We frequently negotiate updated rates, discounts, rebates with our PBM as they're negotiating with manufacturers, the discounts that we're getting and ultimately passing through to the members. We negotiate with them regularly. We also do what's called a market check, where periodically every year or two, we will go out to the market and essentially see what other payers are getting in terms of discounts. And we really use that as our benchmark to try to assess, are we getting the best deals? Can we get a better deal to get better discounts on these drug prices? So we look at that regularly. And then as it comes into what's in our rates and our filing, we're not necessarily filing our contracts as part of the rate filing, but savings generated from some of those initiatives where we do think we would get enhanced discounts or enhanced rebates, we would include something like that in our filing.
So do those rebates get sort of plowed back into for premium reduction, right, down the line?
Correct.
How much of that gets put into premium reduction? Is it 100%? What percentage?
We put 100% into
100%? How about you guys? Same?
100%.
Same with Anthem.
So do you delineate that in your filing? Is there a way for the insurance department to see the path of those rebates towards the premium reduction in real dollars?
Yeah, we fully disclose that in our rate plan.
Same. So, you, one of the companies mentioned about an increase. Actually, I think it was a question from the insurance department about an increase in outpatient hospital services. As you know, the state of Connecticut has been grappling with hospital-based facility fees for years. I think Connecticut, you said you don't pay them anymore, but one of the issues I think we have seen with that is that you don't pay them, but that it gets applied to patient's deductible and then they pay them. So I think in real costs, a lot of times Connecticut will not pay the facility fee, but it'll be applied to deductible. At least that's, as I'm dealing with consumers, I see that. I just wonder, you know, what hospitals essentially have expanded their provider-based offices over the years. I mean, by either acquisition or by building new offices. They've even extended that to urgent care. And you know, basically, they're taking the professional fee, which was the old office-based fee, and adding an additional facility fee, and essentially doubling the cost. A lot of times we see managed care companies and insurance companies simply acknowledging that and saying, okay, this is an outpatient service without challenging it. I guess I wonder if the hospital system owns the facility and employs the providers in that facility, meaning an office space, why is it that you can't negotiate a single rate for those services and drive those costs down?
I can just speak to one example. You know, I think we do attempt to do that where possible. We've worked with large health systems in Connecticut. United has, my team has, to try to get, for example, some of their outpatient locations where they perform a high volume procedure like a colonoscopy at a more market competitive rate. So we do have that in our radar. Your point is well taken. That dynamic does exist. But we do try to tackle that to the extent we can in our negotiations. And we've had some success in taking some of the freestanding locations and really working with the hospital systems, because some of those freestanding locations have a lower overall sort of delivery cost as opposed to their traditional hospital outpatient location, and tried to set location specific rates that are advantageous relative to what it would cost at the outpatient. In some instances, that still is more expensive than what you would buy at a community freestanding non-hospital owned location. But we are definitely aware of that and trying to incorporate that and you know, create that price delta for those new outpatient locations.
And to do it through a single payment, right? Because I mean, there's really no reason to have to pay twice, because it's only one entity that you're paying. If the hospital system owns the office and employs the providers, right?
Correct, where possible, correct.
Do the other companies, are you trying to do that too?
I'll be honest, I don't have line of sight to that personally, but we'd be happy to get back to you with some additional information.
Yeah, and you know, we instituted that policy that I mentioned earlier, where we do not allow for the charging of additional facility fees, but depending on site of service. So
you don't pass that on to?
So, you know, the contracted providers are supposed to follow our policies. So I don't know if that's really hitting the deductible, like you said, but our contracted providers should not be charging facility fees.
Is that for just commercial? Does that include Medicare too? I mean, I know that's outside of the scope. But...
I
yeah.
don't know for sure.
Okay. I guess I know I'm out of time here. So I would ask though, given the fact that the sort of over this course of at least my experience with this, which seems kind of long, companies that really have not been able to control the cost side of things, the negotiated cost side of things. Do you think it would be helpful for, there's some states where hospital systems and insurers have to file their contracts with the insurance commissioner. I mean, you seem to want them at the table, right? Do you want the insurance commissioner to actually see the contracts? Would that actually, or the health, Office of Health Strategy, some kind of state oversight to put pressure on that? And in some states, commissioners can actually disapprove a contract. Is that something that you think we need here? To stop Groundhog Day?
So, I think that probably is not the solution. I mean, I think at the end of the day, we've got to deal with the consolidation. And I don't think filing the provider contracts are really going to do that. Things like I mentioned before, getting rid of revenue neutrality clauses, directly regulating hospital prices is another way. And we've done that before in the past, and maybe it's time to look at that again. I think there are other more effective ways. I don't think you're going to get to the real core of the problem by filing your contracts.
So do you think we'll be talking about unit costs next year?
Well, it's going to be an interesting year with all these new drugs coming out. They're expensive, and so we probably will.
Okay. Thank you.
Thank you, Mr. Ryan. And now we will move to Dr. Deirdre Gifford, who is Executive Director of the Office of Health Strategy. Dr. Gifford?
Thank you, Commissioner. I want to start going back to the comments that most of you made in answer to AAG Ryan's questions about the role of the cost growth benchmark in your trend projections. But I want to start, I'm a doctor. I used to be. I don't claim to be a real doctor anymore, but most of my work is still informed by the days of me sitting in the exam room with patients. And one of the hardest things that a doctor ever has to do is sit down with a patient and try to help her understand what things she can forego because she can't afford them, and what things that the professional thinks would be important for her health that she can put off, and what is essential. And the fact that 46% of people in Connecticut, one of the wealthiest states in the country, are foregoing or delaying care because they can't afford it, it keeps me up at night, and I'm sure it keeps you up at night as well. It's not an acceptable state of affairs in our state. So my mind, as I'm listening to you, is going to solutions. And I'm hoping that we can draw some out as Tom was trying to do. But I want to start by asking you first, Anthem. Your average increases are around 8.3%, 9% requested.
Sorry, 9% for individual, yes.
Do you think those are affordable increases?
I mean, it's relative at the end of the day, right? I mean, when everything else is going up, we're in a place now just in society where everything seems to be going up. Is 9% affordable to any one individual in the state of Connecticut? The answer could be yes, it could be no. I work for the insurance company and my rates go up more than 9% every single year. So, I mean, that's just what we're faced with. Again, the unit cost increases, what we're dealing with from technology, new drugs on the market, all the things that we've been talking about all along. That's what we're up against. So is it affordable? Not necessarily. But at the end of the day, it's the only thing we can do to make sure that the rates are adequate, non-discriminatory, all the things we've been talking about all morning.
Thank you for that. I realize it's a nuanced question. United, your average increases are about 9% as well. Do you think those are affordable?
No, I can't add too much more than my colleague here, except that, and I don't intend for this to be a theme, but I think it is a theme that we need to have the participants and the members that actually utilize the plan to make sure that they're well educated and get the best out of the plan. It's not necessarily just a deductible and a coinsurance. There are other aspects of the program that I think it's important for us to have our membership, the people we're pleased to serve, to utilize their benefits as effectively as they can as well.
So it's on them to.
No, I didn't say that. I'm just saying that they need to be better educated to utilize it more. Obviously, it's not on them because we provide a lot of resources and services to them beyond a phone call. There are member applications. There are resources available that the member can extract or withdraw from the organization. So it's an ongoing process, really.
Thank you. Mr. Meadower, do you think those between 7 and 12% requested increases are affordable?
So healthcare is expensive. It is expensive because of the cost of the underlying provider services. And so I think what significantly helps in Connecticut, and especially in the individual market where we are the subsidies that help our members afford coverage. So, we're actively involved in the Covered Connecticut program. People could get zero premium, zero cost share plans if they qualify. And there's also APTCs and expanded APTCs that help many of our members afford coverage. I mean, we have 88% of our enrollees have the APTC credit. 49.2% of covered households qualify for an advanced premium tax credit that covers at least 90% of the total premium. We have 43.8% of our enrollees that are paying less than $50 per month after APT and state payments for their policy. So yes, the overall expense is high, but at the same time, we have very important programs in Connecticut that help our members, and I encourage that those continue.
Thank you. So I want to go back to the relationship between the cost growth benchmark and your projected trend, and or your requested increases with the underlying trend that's behind them. You explained, and I think we understand that you use a different set of criteria for in calculating your requested increases. Namely, we use for the benchmark the projected growth state product and median household income. You use underlying medical trend, utilization, and costs, et cetera, as you've explained. And therefore, the two end up at a different number. My question is, as Tom was probing, to a certain extent, the trend is a product of the negotiations that you undertake with our provider community. So I'd like to ask you some questions about this picture. And this, by the way, is publicly available. I clipped it off the web this morning from the Nashby Hospital Cost Tool. The pink bars, as I mentioned, represent variation in hospital costs, inpatient and outpatient combined for commercial payers. And this data comes from the RAND 5.0 study, which is based on our Connecticut all-payer claims database. First, I'd like to ask, does this variation across hospitals look familiar to you? Would you agree that there's this type of variation within your Anthem contracts between hospitals?
From my understanding, yes. And again, I'm not too close to the actual payout, but we can get that information confirmed for you. But yes, that is my understanding.
Okay. And so is that variation in what you pay hospitals based on the quality of care that they provide?
Yeah, I mean, and that's where we go back to the value-based contracting that we have with our hospital providers. So at the end of the day, what they are being paid is fully reflective of pay for performance and quality measures.
So the price that you negotiate with hospitals is negotiated based on a measurable quality score?
Well, I mean, it's more incentive based. So at the end of the day, if they're not performing, they're not going to achieve those higher numbers that you might see up there. So, and I can't see, exactly who we're talking about, or even if the
Yeah,
hospital
the
systems are up there, but
sorry, they don't show on this picture.
yeah, that's
You have
fair.
to hover over them on the website.
Yeah, so I mean, without seeing the providers, and again, not being close to the negotiations myself, it's hard for me to elaborate on that. But at the end of the day, we are driving payment based on performance. So at the end of the day, if a hospital is performing and providing those quality-based outcomes, they are incentivized to produce for us those quality outcomes. And if they're not, they're going to get paid less than they would otherwise. So it's kind of half a dozen of one, six of the other, where you're kind of looking at it from two different ways. without driving that quality-based outcome, we're just paying for volume. And at the end of the day, that's going to drive up some of those. So I'm sure if you look at one of the hospitals there, a few of the hospitals there, some of them are purely volume-based, others might not be.
So this is unit price, average
Okay.
unit price. So if I understood you, you're saying that Anthem bases their hospital price negotiations on quality. So I would love to see the information that explains how Anthem is basing their hospital prices on quality. I think that's new information that we haven't heard before.
Yeah, and we can provide more information, like I said.
Okay.
I'd be happy to further the conversation from here.
The other question I have is the green bar, as I mentioned, is a calculated number based on the Medicare cost reports of a projected break-even cost. So it's somewhat a reflection of the underlying cost per hospital day for that particular facility. So you can see that some of the commercial prices are more than double the projected break even, and some of them are very close, meaning the underlying costs per facility are very variable and they don't seem to bear a relation to the commercial costs. So does Anthem look at the underlying costs of providing hospital care when negotiating prices?
And again, without me being too close to the negotiation process, I can't speak specifically to that, but happy to find out for you.
Thank you. So I'll ask you from United, does this variation in hospital payment or price look familiar? And I think you mentioned, Mr. Flood, that you see this kind of variation across hospitals in Connecticut.
Yes, Dr. Gifford. We do see, and I can't see the names, but I see the variation just in general as I look at the Connecticut market. I would say that just to kind of answer your question that you posed to my colleagues at Anthem, quality is a component of this this chart, but it is not the only driver that creates the differences between these hospitals. So we will at United, we have a wide variety of different contract types. You know, one of them is really just paying a slightly different or a higher fee for service opportunity if the hospital has hit quality metrics, readmissions, and kind of HEDIS type industry standard measures. We also are moving our accountable care organizations as far down the path of total cost of care and the assumption of some level of risk, kind of an achievable and fair risk, not a put you out of business type of risk, because that's the business that we're in. We're a risk-bearing entity, but we do have some element of risk, for example, on the PMPMs that we pay out through our accountable care organization. So that will also influence the total reimbursement. But one of the bigger, I would say, influencers of this chart would be the mix of business at each individual hospital. That's a large one. So if a particular hospital in a particular part of the state has a different mix of commercial versus government reimbursement, that hospital may feel like they need to ask for a higher commercial reimbursement to help them get to a positive operating margin given their cost structure. And I'm talking about not-for-profit hospitals, right? So they're running a 2% margin. They're not running large margins, but
And do you verify that when
yeah,
they?
yes.
Do you verify the relationship between what they're actually paid by the governmental payers and their claim of underpayment?
We do. I personally will look at, the publicly available cost to charge data and then look at my discounts and kind of correlate the percentage of margin that I'm paying through my commercial agreement with that hospital relative to their cost. And also looking at the mix that particular hospital has between Medicare and Medicaid, self-pay, uncompensated care and commercial. And we do look at that in our renewals.
Because I can tell you, thank you, that there is no relationship between the height of those pink bars, which again is relative price paid by commercial payers relative to Medicare. There's no relationship between the height of those bars and the percent of Medicaid. So in fact, some of the hospitals that have the highest pink bars here have the lowest percent discharges of Medicaid. I'm not talking about Medicare fee for service or Medicare Advantage.
Yep.
But we hear this a lot.
Yeah.
And I just want the CID to know and the public to be clear that commercial prices, and this is price per admission and per service, is not related to the percent of business generally. There's
Yeah.
not a one-to-one correlation between the percent of government business and the commercial price.
That's right, Dr. Gifford. And that's an influencer, so, what influencer is the quality programs that we have in place. Another influencer could be their mix of payers. Another influencer could be their geographic location, where a hospital just has the geographic service area where they have been able to, and even if it's not a large system, it could be one hospital, as an example, that's able to achieve reimbursement that's among the highest in the entire state, just based upon their unique service area, the way that folks consume service in that particular geography, and the leverage that comes along with that. So that's also a driver. And then obviously we've talked about it a million times, really just the highly leveraged systems that have multiple locations and many physicians' ancillary locations and hospitals across the state. So those, I would say, are the influencers of, from my perspective of the chart. It would be those four things. It would be the quality component that we do look at, the mix of their payer mix uniquely, their geographic location and the advantage or disadvantage of that, and the size of the system and the leverage they bring.
So are you suggesting, thank you for that, very thorough response. Are you suggesting that there should be a correlation between commercial price and percent of government payer?
No, I'm not. I think the correlation really in a perfect world would be that it's quality. And I think that's what we're striving to try to get to, and outcomes.
Thank you. So I'll ask you the same from Connecticut. Do you see, does this variation in hospital pricing look familiar?
Yeah, again, I can't see it specifically, but I have to echo what everyone else here has said. There is perceived quality too. There are certain customer choices where they really want a hospital system in your network, and it's a must-have hospital, and they want to buy a plan that has that hospital in it. So that provides market power for the hospital system. And so, there is a quality component here, but you are right, it's not all of it.
Thank you. So you explained to us that the trend is different from how we calculate the cost growth benchmark. And I understand that. And yet we see that there is this level of variation, which you all acknowledge, which is not related primarily to quality. It's related to market forces. And so that to a certain degree, that trend is under your control. So can you explain, with this level of variation, explain to us and to the insurance department why some of these, at least some portion of this trend, is not excessive? If it's based on this type of variation, which is not explainable by quality or health outcomes, but is driven really by your negotiation process, as the AAG was pointing out, why is it that some portion of this is not an excessive increase in cost?
Well, cost is the key issues here. Until you're able to bring down the cost, which is the top negotiation that all carriers out here are talking about. So until we're able to negotiate and bring out the cost, as an actuaries, we have to develop based on what we see from historical data, and then based on our standard actuarial practice, we have to make reasonable assumption on our trend to project it out. So until you can solve the underlying cost of care issues, I'm not sure if, as an actuary, there's much I can do in terms of the trend assumption.
So I guess, again, back to my question, do you need help? Do you need the state to stop that? Do you need the state to put a cap in place? Do you need the state to oversee those negotiations that you're not, I mean, you guys are telling me that you're not able to negotiate lower cost. So, and again, I've been here since 2009 and we've been talking about it every year. So what needs to change? And everybody's asking it. Commissioner Mays is asking it. Everybody's asking it. Everybody wants to know. And we have to do something because it is unsustainable. It is. You know, I mean, the cost shifting that happens in these plans is making them unaffordable, except in the marketplace, maybe where there are tax credits. But for people in the middle, they're getting slammed. So, and so what's the answer, I guess, is the question.
I think we discussed about just last year, let's have the hospital and PM sit at the table and talk about it. So, I mean, as an actuaries, we have to use whatever the historical data and whatever the trend that we see, that's how we're going to reflecting in the premium rates. That's pretty much what we can do on our end until you can solve the underlying problems. It's not going to change what we file in our rate file.
How about, and I mean, I know you're not prepared for this year, but maybe next year as part of the rate filing, you not only show, you demonstrate how you're driving down that cost. You demonstrate what your plans are and your projections are and your goals, or it's getting to a result that's consistent with the Connecticut cost growth benchmark as part of the filing. Because, I mean, again, if we just sit here and I understand from an actuarial standpoint, the numbers are the numbers. You have to deal with the numbers. I understand that. But your company determines in part what those numbers are through its negotiations. So there's got to be a plan, and that should be part of this process because it downstreams, and we just keep going back to the same thing every year. Unit costs going up.
I'm going to see the rest of, I think I'm over my time. So I'm going to, I'm going to move on and let the health advocate. So Connecticut and United will be off the hook from my final question. Thank you very much for your responses. I appreciate it.
And could I say off the hook for now, but if you have the questions to submit to them so they can respond as we move forward.
Oh, I appreciate that, Commissioner. I will do.
Thank you. And now the Connecticut Healthcare Advocate from the Office of the Healthcare Advocate, Sean King. Sean?
Thank you, Commissioner. Again, Sean King, Acting Healthcare Advocate for the state of Connecticut. Dr. Gifford, I may give you a little bit of your time back because I don't have a whole lot to add. It's been covered pretty well by the questions already asked by Attorney General, Assistant Attorney General Ryan and Dr. Gifford. One question I did was kind of wondering about though is because I heard earlier that there's a lot of the conversation's been around the consolidation and the market power that hospitals have, and I heard some discussion about basically there are must-have hospitals, but it also I also have the sense that there may be some hospitals that are not necessarily must-have. To what extent are we struggling with network adequacy requirements, and in spite of a ban on all or nothing provisions in contracts, are there still all or nothing posturing being done by the health systems using their market power and that leverage in order to get those not so must-have providers in the network along with the must-haves? In any order you want.
I would say that the system agreements that we negotiate so that, you know, multiple hospitals, a physician group, for example, and a bunch of outpatient freestanding locations, that type of a renewal, they are all or nothing. And I think that was probably the intent of the consolidation of that system over time to because many of our larger systems are, in the state are a combination of very large tertiary facilities, but also with one or two community hospitals. Yeah, I think the negotiations I've experienced in my role at United are all or nothing with the systems.
Yeah, and I can jump in and I can agree with that. I mean, we are negotiating with very large hospital systems. And if you don't have one of them, it is difficult to meet your network access requirements. And so if you have two that say you want to negotiate or push out of the put out of your network, it's very difficult to meet network access requirements. And maybe there are ways to change those requirements. We have new technology, we have telemedicine, telehealth. Maybe we can factor those into the network access requirements. So they're a little more conducive to being able to negotiate against some of these large hospital systems.
Yeah, nothing more to add than what my counterparts here said. I mean, the consolidation is what it is. We're looking at two major hospital systems and a few ancillary hospitals. The state's allowed these consolidations to happen. So at the end of the day, our negotiating power has been reduced significantly by that impact. And I think that's what we're up against. And we're all kind of saying the same thing here. As far as help, Tu said it before, I think just getting us all to the table. I don't think we need to do anything more than that. Let's start there, bring everybody to the table and just have an open dialogue and conversation to talk about where we go from here. I think we all have an appetite to do that. And I think, it's just a matter of bringing us all together to make that happen.
Follow-up question. If you were able to eliminate some of those non-must-have facilities, would it matter? Is there a lot of cost difference that it would make? Would it bring prices down if you're able to do that?
Yeah, I don't know that we can quantify it here, but certainly if we can go into a negotiation and there's a threat that we will term the contract or not continue the contract, we have much more market power to negotiate better rates.
Yeah, and I mean, we talked about network adequacy. If we lose one of the major hospital systems, we don't meet the requirements. So I think from that standpoint, we're open for, again, additional conversation and dialogue around that. Is there an opportunity? Yeah, I think there is.
Just to comment on access real quick. I mean, obviously there is a little bit of it. So you have the regulatory requirement of access, which, we certainly abide by, but then there's the practical, real world, kind of like, can my mom and dad find a primary care doctor and be seen within a reasonable amount of time? And I think those are two different discussions in some instances. So even if a hospital and the associated physicians could be taken out of the network to try to improve cost, I think we all have to be kind of cognizant and sensitive to the fact that even though we may, in one instance, meet the regulatory requirement around access, we may not have good practical access where people have to wait too long to be seen for vital services. It's just something I think about when I'm making network decisions in my role.
Yeah, and I would like to sort of comment on the idea that negotiation is the problem, that we are not negotiating strong enough with these or aggressively enough with these hospital systems. We have a very good negotiating team, contract team, and they negotiate every day trying to get the best price that they can, given some of these challenges we're talking about. But to really address some of these issues, we got to go beyond the insurance carriers. We got to do things that really get all the players in the ecosystem involved. We got to deal with the hospitals directly, not just through the insurance company. We have to deal with the pharmaceutical companies who are charging significant cost and prices because of their power, their patent power. So, I think the ACA came in, regulated the individual market, and that's been relatively successful. But our margins are capped already by the medical loss ratio rule. The hospitals may need a medical loss ratio rule, or the pharmaceutical companies need a medical loss ratio rule. So, I don't want people to leave this room thinking that we're not negotiating as tough as we can with these hospital systems and with the pharmaceutical companies.
So my other sort of general question is, and kind of follows up on that along those lines. What are there any executive compensation incentives that exist in your companies that reward people for putting a certain amount of downward pressure on prices. If say somebody was able to negotiate a contract that was in line with the benchmark as opposed to twice the benchmark, is there an incentive for the negotiating team, the executives, other folks within your companies that would reward that outcome?
So I don't think there are directly. In fact, we might have regulatory problems with that. It could look like you're trying to incentivize executives to deny care. So there's not a direct provision in our executive compensation that does that.
Quick answers, no.
Same here, no.
That's all I had.
Thank you, Sean, and Mr. Ryan, Dr. Gifford. We've got a few extra minutes. I think Sean has yielded that time to you if you would like to continue.
Thank you too. In fairness, I will ask United and Connecticut the same questions I was asking Anthem about the basis for that variation in care. Is there anything else that you want to add? Excuse me, variation in price. Is there anything else that you want to add as to explanation for that variation that would help us understand if any of those prices are excessive?
Dr.
I think there's been, go ahead. Oh, I would just add that when we look at our pricing from insurance company side, we do spend 87% over the last 3 years, and that's what we're projected to spend going forward on direct medical costs. I mentioned this before as well, but there's a lot of additional risk going into the market with Cigna's exit, and we are only including 2.8% risk for that, which you can call risk, profit, you can call it whatever you want. But that is a pretty small amount. We have seen that variation from year to year has been significantly more than that. And from an insurance company side, we definitely are not doing anything excessive there. I would also add that we've done things like reduce administrative costs for 2025. We've reduced selling costs. So we've really done what we can to make sure that rates are not any more than they necessarily need to be to make sure that we don't lose significant money and just make a small profit. So from the insurance side, I strongly feel that these rates are not excessive. And I think if the question is whether or not the providers' contracts are excessive, I do think that we need to have the providers answer for themselves to some level.
Thank you. I appreciate that. And I was asking specifically the question about the variation in inpatient and outpatient hospital prices and whether any of those were excessive, given that we've established, I think fairly clearly, that they're not based at least strictly on quality or health outcomes. Mr. Meador, do you have anything to add about the question around excessive?
No,
prices?
again, I think it's also important though to make a distinction between what's actuarially excessive and from a rating standpoint, the R rates versus the provider's costs and the underlying costs. And those are, as we've said, high because of factors other than quality.
And so I would like to follow up on your getting to solutions, your suggestion that we all get in the same room, because I think there have been a number of fora where we have done just that. In fact, we brought the parties together a number of times over the last few years, and you all received a direct ask from the governor to put forward solutions to the issue of affordability. So we're still open to those suggestions. If there's a forum that's different from those that we have convened in the past to have a conversation, we're all ears and would love to know who the right participants should be. I think the bottom line, Commissioner, as we've heard, is that there is not sufficient incentive built into the system to bring the parties to the table. And we appreciate your frank responses and some of the challenges that you face in this price variation. But the fact of the matter is everyone has a role to play. And we are not seeing, to Tom's point, we are not seeing the movement in unit price and therefore in affordability that we need to see. So I will speak for the Office of Health Strategy, and I think probably for Commissioner Mays as well. If you have ideas about solutions or forums in which to bring people together, we would be all ears. Thank you, Commissioner.
Thank you, Dr. Gifford. Mr. Ryan? Thank you. Before we move to our elected officials, I got 3 questions, if I can read what I was scribbling down here. I'm going to start with you, Brandon. And, you know, I'm going to echo what Dr. Gifford just said, the idea that people should get together in a room, because we have had those people in a room. And as you were talking, I was thinking about that quote that is usually misattributed to Al Capone. You can go further with a kind word and a gun than with a kind word alone. Why, listening to what the Assistant Attorney General has suggested, why would you be opposed to the involvement of state government here as it is in, say, Rhode Island, where there is a cap that's based, cap for spending that's based on the CPI? And I think, as we saw earlier, the costs in Providence are 5% below national averages. So not quite sure I understand why you would resist the intervention of state government in that way.
Yeah, and I don't think I'm saying that we resist it. I think we just need to further the conversation outside of this forum here. So, you know, I know we've had, and I wasn't necessarily, you know, partaking in any of the prior sessions that were there. I think some of my counterparts within the organization were in those sessions. And I heard that they went very well, and I was able to watch some of it myself as well. So, it feels like it's a conversation that's had, and quite frankly, just doesn't seem to go anywhere from there. And then we're right back here every single year. So, you know, it's, you know, Mr. Ryan has said it before. It's like he's been doing this a long time, but we're still in the same place as we are today. And we're always here. You know, we're always here defending our rate filings every single year, but it feels like an us against them to some extent. So I think we very much embrace your participation, the state's participation in the conversations. To what extent? I just don't know if I'm the one at liberty to say, but at the end of the day, having that conversation with, you know, our leadership team here in Connecticut, you know, all the folks that work with us on the provider side, I think we just want to come to the table and have that open dialogue.
Thank you. Moving over to Mark, secondary but related question. You said that you would not, or this is my interpretation, would not necessarily support having contracts with providers be public. For some of us who look at sunlight as a disinfectant, who keep hearing that the reason our insurance rates are going up are because the costs are going up, it's very difficult when we can't see what those costs that are increasing actually are. Do you not think the public would be better served by having that information available to them so they can see, as they choose which hospitals to go to or which providers to go to, who's being reasonable and who is not?
So, you know, our contracted rates are already public now. I mean, because of the CAA that was passed, they're on our website. So it's not always easy to navigate those machine readable files, but they're already public. So, and I think better tools are being developed, you know, as we speak, so people can actually see what the rates are. And so, you know, I don't think that having a whole nother process just to file our contracts, that's really going to make a difference. I think to really address the problem, you have to address the problem with consolidation and the market power that the hospitals have because of that consolidation. And again, and not to harp on pharmaceuticals, but the pharmaceutical costs are significant. And you know, part of that, you understand, there's new drugs, some breakthrough drugs that are coming through. So just an overall cap on costs, that's very arbitrary. You could have some innovation that a cap would inhibit. So, you know, it's complicated, but I think, again, to go back to my sort of point, I think we need to find a way to really directly regulate the hospital systems and the drug companies.
Thank you. And United, saving the best for last. In terms of the questions, I'm going to hit you with two questions. One is we heard that some of the variation in the price and the cost and the price paid as a result of quality of care. Can you tell me in general, now I'm not looking for specifics, but just to get an idea, what the median difference is? How much does in terms of a percentage increase, would a top quality institution get as opposed to one that's regarded as acceptable? So that's question one. And question two, we heard at the end of this discussion that there really is, nobody gets more in their paycheck for keeping the cost down. There are no incentives for that. Whereas if we're operating on a percentage of cost, it seems like everybody's incented to watch those costs increase, except for consumers. What would you suggest as a system that would help provide incentives to keep costs down?
Perhaps I'll answer the second question first and then ask my colleague to speak to the first one. But we are incented to try to keep costs down. Unfortunately, they just have a lot of factors that generate an increase in cost. So the main one is competition. So we want to compete with our peers here. We want to be competitive. Often it goes beyond cost. It goes into delivery, member satisfaction, employer satisfaction, products that are different than perhaps others in the market, introducing technologies and innovations that actually create a healthcare experience that's different. So I would say that we're highly incented to keep costs down. I certainly understand the narrative around cost increases, and there's no harm to a carrier, but there is, because we want to be competitive. And we kind of to the question earlier about opportunities, I would say that having the flexibility to be innovative, have flexibility in, to the extent that we're able in the filing process. The filing process itself is great. Product offerings and trying to get other products out into the market is obviously very helpful, but a little more restrained just because of what ACA, buckets around the things that we do today.
And Commissioner, to answer your first question around quality and how it plays into the overall reimbursement, I don't have an absolute number in terms of the total dollars we have tied in or the percentages. Certainly that's something we can follow on or talk about. I would say that, the contemporary agreements that we are structuring both on the physician and the hospital side, in some instances, the amount of increase in a contract year can be as much as doubled by high performance. So it can be material. So I've seen between, 50% additional earning opportunity and a doubling the earning opportunity through hitting quality and cost metrics in the agreement.
Thank you, because that was what I was looking at. What is it, de minimis or is it material? And you seem to indicate, if I'm getting this right, that it could be material in many
We're
cases.
trying to make it more material in every renewal and make it a fundamental component of every renewal we do.
Thank you. Now we are going to turn to our elected officials, and we will begin with the chairs and ranking members of the Insurance and Real Estate Committee. And I am pleased to introduce Senator Tony Wong, who is a ranking member. And Senator, you have 10 minutes.
Thank you, Commissioner Mays. And I want to thank you for you and your staff for making this an opportunity to have a public hearing in the LOB and via Zoom for us as legislators to be able to voice and, if not possibly, vent some of the frustrations of many of the constituents that we represent. So before I begin, I just wanted to kind of give a caveat to the insurers that are here. Thank you for being here. Thank you for your role in being a business partner in the state of Connecticut. But I understand that you're the messenger here. You are the compiler of healthcare costs, which in this state and in this country is unaffordable, unsustainable, and an incredible burden on the consumers and the constituents that we represent. But I will echo what Assistant Attorney General Ryan said. I've been coming to these meetings for the past 10 years, and every single year it is a rate increase. You could have surprised one of us and knocked us on our floor by saying, hey, this year we're asking for a rate reduction, but it's never happened. You know, the landscape might have changed, the cost factors might have changed, but one thing has remained constant. You continue to ask for rate increases. And that is where the frustration and the venting you will hear from many of my colleagues and many of your consumers, your ratepayers, that feel as though you are tone deaf, that you are not listening to the struggles of them, combined with what people read about Wall Street profits, what people read about outlandish executive compensations, and all the largesse of corporate benefits that are at the backs of ratepayers in this state. So this is what we're looking for today is I'd like to hear from you some of the solutions that we as legislators, it is not a batting day. It is important for us as a legislator to work with the governor's office, with the Office of Health Strategies, with the agencies, and as legislators on a bipartisan basis to find some solutions. But the first question I have for you is, do all of your businesses service and administer self-employed insurers, meaning large corporations? Just a yes or no to each of you, if I may.
Yes.
Yes.
Yep.
Do you continue to raise double-digit rates in your negotiations with those companies and not get the pushback and the negotiations and the consideration of cost efficiency that the AAG Ryan talked about over and over in cost indexing? Do you?
I can speak to that first. The trends utilized for small group are very similar to the trends utilized for large group as well as self-funded employers.
Do you ask for double-digit rate increases every year? And unfortunately, on the backs of small businesses and individuals, get approved by those entities?
Well, it's an ERISA plan. So, and if it's self-funded, a lot of those decisions are really made by the employer and the choices they make. But in general, sometimes they do have double-digit rate, if you will, cost increases, and sometimes they don't, depending upon what types of applications of, if you will, affordability initiatives in the larger group market. Could have disease management programs. They might identify a particular risk that's unique to their employer population, and they will go at looking at ways to manage that membership a little bit differently. There could be the list can go on, but that evaluation happens. As it relates to small group, we do similar things like that. So we do have medical management programs and things that do take care of populations where if you're an employer and you're in small group, you're not very credible by yourself, but within all of our clientele, not just here, but also on a national basis, we have programs available for helping to manage and support members in those times of need as well.
Thank you, Mr. Brandt. Mr. Mitter?
Yeah, so we have a small, large group ASO business, and they get the same rates that we have in our commercial business, insured commercial business.
Mr. Rousseau?
Yeah, and ours will vary depending on the customer. So much like my colleague here too was saying before, actuarially we're projecting ahead. So at the end of the day, a large group self-insured client, we're going to treat the same way as we would the entire small group block or the individual block. We're going to trend forward and see exactly what that claims experience is expected to look like and base the rate on that.
Thank you. And the reason I asked that question is just as the AAG Ryan and Dr. Gifford articulated, there needs to be more of an engagement in the solution process, allowing our insurance departments and the various agencies with the expertise to be able to help and negotiate and to be able to look for best practices and not simply count on your request every single year with your actuaries who are very talented, but your basis based upon your perspective, not the other perspectives we've been able to gather. And so the first question I have is benchmarking as one of the solutions. What is the enforcement factor just based on that chart that was presented by Dr. Gifford, we've exceeded the benchmarking average basis. What is the incentive and what is the potential enforcement if you don't meet those benchmarking criteria that we've resulted from?
Yeah, I mean, from an Anthem perspective, I think it is a part of every negotiation that we have with any provider contract. So I think it's always an element there. In the enforcement of it is difficult. So at the end of the day, again, when you don't have that negotiating power, you're dealing with a very consolidated hospital system. That's where I think the difficulty comes into play. But we actively have those conversations. I think it's, again, having that forum where we're all at the same place at the same time, talking about it outside of just the simple renewal that happens, or, complex renewal that happens every few years with the hospital system. It can't be a one and done, and then you come back 3 years from now and see where you land. It needs to be more proactive on an ongoing basis, and I agree there.
Yeah, sort of get back to my earlier theme, there are other states that have hospital systems do performance improvement plans directly with the regulator. And that is something that we should consider here. So again, a sort of direct action, not through the insurance company, to deal with the hospital system market power.
I just would comment that I think those are fair suggestions by my colleagues at both companies. We don't have anything additional to add. Senator, thank you.
Thank you. Now, two of the major factors that's been presented by your actual analysis was looking at hospital cost. And we've addressed some of that in regards to benchmarking and your fee-based negotiations. The other is pharmacy, prescription drugs. Now, as I understand, you have a vertical integration with some of your organizations that we're talking here. Anthem has obviously DomaniRx, which is a new name, right? Which is the combination of Humana and an IT organization. And then United Health has Optima RX. And just with Connecticut Care, you use Express Script, but you don't own them.
That is correct.
Right. But in regards to the two entities that have ownership in PBMs that dictate prescription drug prices, we talked about hospitals and the look at their vertical integration and looking at all their cost analysis and P&L. Wouldn't you think that'd be applicable to you as an insurance conglomerate to look at your P&L relative to the PBM being a profit center or a loss center to your rate requests? As you talked about hospitals and their vertical integration and their cost considerations, why have we not considered your relationship, your ownership of PBMs as part of the cost of healthcare in your rate setting request? So this would be applicable for Anthem as well as for Connecticut. United Healthcare, I'm sorry.
Yeah, so for us, it's Carolina X is the name of the pharmaceutical PBM that we have.
Thank you.
But for me, it's the same issue that we're talking about with the hospital systems. We don't dictate the cost. So at the end of the day, the pharmaceutical company is the one that's dictating the cost. We can negotiate on what we feel is an appropriate price from there. And I think that's where we're probably struggling. When you have all these new drugs coming to market, and I mentioned it in my opening statements as well, there's value in these new drugs coming to market and saving people's lives. We all know that, but at what cost? That's what we're here to address, right? So at the end of the day, it's a lot of money, and we need to figure out how we're going to address that piece of it first. And it is going to come down to stronger negotiations with the pharmaceutical companies, just the same as with the hospital systems for us.
Thank you for the question. While OptumRx is a UHG company, they are separate from United Healthcare. But if you broaden the conversation to negotiating with OptumRx, and I'd mentioned earlier, we actually have our own team that negotiates with them. The context would also be helpful to broaden it to not just small group, but it's also in large group. We compete with, folks at this table in the large group, fully insured environment. But on a self-funded basis, we also compete on a national basis, not just with the folks at this table, but many national self-funded carriers, as well as TPAs. So we're fortunate for, if you will, Connecticut small group ACA in that we have leveraging power of all those other entities, in addition to the fact that we want to compete on a national level, but also on a local level, say with a TPA that's got self-funded business that uses a third-party pharmacy PBM. So we do directly compete with our competition relative to these agreements. So we are motivated to be competitive and have the best quality and affordability outcomes relative to the PDL that we do provide.
I appreciate the answers, but for me as a consumer and looking at a perspective that you report all your business operations to Wall Street as one income stream, but when you make these rate requests to the insurance department for setting, you look at your healthcare cost, and it's only based upon your healthcare costs. It does not encompass your portfolio of business operations. I struggle with that. I struggle with that straight pass through to the consumer in regards to healthcare costs when other parts of your business benefit. And when we see the Wall Street returns and consumers continue to feel the sting of additional rate increases, while we see the buffer of your other business and vertical integration on your business, I struggle with that. And I feel that same struggle in a parallel that we're seeing right now with consumers as it relates to our electric utilities. It is the same system that reviews rate requests based on energy generation, but not on their business profit centers elsewhere. Again, it is the consumer and the ratepayer that bear the brunt of your actuarial analysis of purely healthcare delivery, not the basis of how you run a business. I hear criticisms in hospitals and their vertical integration, but when it comes to how you operate as a business and how you are setting rates to this request to the insurance department, we're only focused on your cost of healthcare delivery, not the profits that you make in other parts of your business. So perhaps that may be an opening of discussion when we're looking to reduce cost. One last question, if I may, is at the indulgement of the commissioner, is how can we manage a system that does not go into some of the advocates of a government-run system? How do we channel and leverage the expertise and the experience that you all have? And in Connecticut being the insurance capital of the world, how can we create a better system where you are viable and you are successful, while at the same time leading the marketplace? As Dr. Kipfer wrote it in a chart, Massachusetts, our neighbor, and Rhode Island have significantly reduced costs. Maybe it's the premise that Connecticut consumers can pay, but I'm telling you loud and clear, they can't. They're compromising food on the table and benefits that they need to take care of in order to pay for health insurance that they hope they never use. So my ask of you is, we'd love to have you come to the table as the AG, as well as the Office of Healthcare Advocates and the health strategies and the commissioner. I ask for you to come with real solutions and real genuine efforts in recognizing that in the profit you make at the cost of your ratepayers, that you need to be more transparent, you need to be more accountable of your P&L, and you need to respect the consumers that pay your rates. So Commissioner, I appreciate the opportunity. And as I said earlier, we're representing our constituents as elected legislators. We're going to give them a voice that they feel as though that is not being heard, and that the reactions and some of the claim approval or rejection processes are tone deaf. So I hope you'll take that to heart. And again, as I said earlier, I appreciate you being here, and indeed you're the messenger of being a cost compiler, but you're also a big part of the hopeful solution that we need to have. Thank you, Commissioner.
Thank you, Senator. And our next speaker will be the ranking member from the House for the Insurance and Real Estate Committee, Representative Cara Pavlock D'Amato. Representative.
Thank you. And I just want to also thank everybody for participating today and for hosting. The prior authorization process seems to be costing hospitals more and more every year and seems to be more, I will say hospitals have to even add staff just to accommodate and process prior authorizations. So would it be possible for each company to provide us the number of claims submitted, number of claims or requests that have been denied, the requests that have been overturned afterwards, and any that are still pending for 2023? I'm hoping we can get that data because I haven't been able to see it and really look at it to see if it's something that we can address legislatively. And with that, I also ask, what steps have companies taken to audit or streamline this process for each of you?
Let's begin with Anthem.
Yeah, I don't have any of that with me today, but I'm sure that's something we can take back and see what information we can provide for you. So that's a takeaway for us.
I believe we have some information available. I think I believe we provided it in the past. I think there's a, perhaps a consumer report card that might have provided some of that information as well. It's slightly delayed, I think, timing wise, but something that's produced last October, I think. As for what we're looking at, we are evaluating the whole pre-authorization environment. We should have some, if you will, announcements in the fall, but the idea is to reduce unnecessary pre-authorizations that, perhaps aren't necessary anymore because technology's improved. So having the information available is actually already at our fingertips, and now we're using technology to utilize that information, make the evaluation, and reduce the friction, basically, for either a provider or our membership.
Thank you.
Yeah, and we can provide at Connecticut some of that data for you. It does exist. And we have done a lot of work at Connecticut to reduce the services that we require prior authorization. We actually looked at those services that we just commonly approved. And we said, hey, we don't need to do prior authorization for those services anymore. So we reduced that burden considerably. Now, on the other hand, I would strongly recommend that we don't pass laws to restrict prior authorization because things change. It's a very dynamic model. I think we've touched upon that before, but we do try to reduce the friction that happens with prior authorization, but it's a very useful tool in the right circumstance.
Thank you for that. And yes, I would prefer to not have to enact legislation dealing with it. It's private contract. So I am along the same lines as yourself. Then with my request also, if you could provide some of those codes where there have been changes over the years where you automatically accept it, I'll say in the last few years. And if it goes back a little bit further, you find some that would be useful, then, because I'm hearing that as well, that there are common codes and therapies and different things that are always accepted, and yet they're still required. They're still required pre-authorization. So thank you very much.
Thank you, Representative. And now we are going to begin the public comment portion of the meeting. We're going to begin with our elected officials. Each official will have 5 minutes to speak. Then we will take a short break. And after that, we will invite members of the public to speak. Members of the public will each have 3 minutes to make their comments. Over in the corner, Anna Pratt will be our timekeeper. Anna will be ensuring the proceedings adhere to the allotted time. When time is up and she gives you the signal, please be prepared to conclude your remarks. Allison Kiff will be calling the elected officials who are signed up to speak. And if I could just ask Allie to read the list that we have as of now.
Yep, we have Representative Tom Delnicki, Representative Stephen Meskers, Representative Keith Denning, Representative Tammy Nuccio, and then Representative Holly Cheeseman.
Thank you. Let's begin with Representative Delnicki.
Thank you, Mr. Commissioner. So
this is not a Q&A, as I understand, it's just comment per se. Dr. Gifford struck a key note when she spoke. 33% of the people are struggling to pay for care. 46% delay foregoing care. And 78% worry about paying for care. Those three comments are burned into my memory just from hearing them. And my questions, and I don't expect them to be answered at this point, are as follows. Which companies that are involved here are publicly traded? Which ones have favorable profit and loss margins? My good colleague to my right touched on the issue of the profitability of the entire company that has many divisions. Which ones are profitable and which ones aren't? And especially the division as it applies to healthcare and to the other divisions as they are a backstop. The benchmarking, you know, if we take a look at benchmarking as an overview versus inflation, in 2022, 9.5% inflation, 2023, 4.06, 2024, 3.2, and our benchmark should be 2.9% for the coming year. And that's analogous to the inflation rate. And we haven't seen that as evidenced in the rate request. I haven't been attending these meetings prior to becoming elected to the 14th House in South Windsor, but I have attended every one thereafter beginning in 2017. And it almost strikes me that it's the same story over and over again. Well, you know, nuance here or there, but the end results are the same. And that I find problematic because I would have hoped that there would be more economies of scale, more savings, better delivery of services, and meeting those benchmarks. That's something that was very important that we established, the benchmarking to try to rein in the costs while providing quality care, because everybody deserves to have quality care at a reasonable price. And we depend on being able to purchase that insurance policy, something that I hear from my constituents time after time. And now they're making the analogy, as the good senator pointed out, to electric rates. And now people are saying, where does it end? I know that business is entitled to make a profit, but the entire business, as an overview, all components, can produce what that profit is and satisfy the stockholders without overly burdening and overly charging for the healthcare policies that people desperately need. And I think that's probably the real clear message that has to come through, that every year the rate request is overly burdened. We instituted benchmarking to try to call that back, and we're not seeing that happen. I hope that message comes through loud and clear. I thank the commissioner for actually having turned these meetings, because I can remember the one in 2017. I think myself and I think Senator Anwar were both attending at that point in time. And that was it.
And now you've brought these meetings into the LOB where people can actually see it on CTN, can submit testimony, and can sign up to speak. And I thank you, Mr. Commissioner, for that opportunity. And please take my testimony here to heart, because something has to be done to resolve this. Thank you.
Thank you, Representative. And our next speaker will join us remotely. It's Representative Stephen Meskers. Representative Meskers.
Thank you, Commissioner. I want to thank you for your testimony or for your leading the conversation today. There's a couple of points I think we need to bring forward, a couple of concerns that I think are so obvious to me. One, what I'm hearing from the insurance industry is that there's difficulty here today negotiating rates with the hospitals. What I'm hearing is that the leverage they have in a very consolidated system that we as a state have allowed to consolidate is that they're not comfortable and the pricing. I'm hearing and I'm concerned that they're unwilling to suggest that we have a more public discussion of the pricing. And more importantly, I think, Commissioner, is that I didn't hear one suggestion, apart from a oblique criticism of mandates. I didn't hear any suggestion about what we can do to improve the negotiating skills or the negotiating leverage of our insurance industry, but both pharmaceutical and hospitals. Because it's clear to me if we can't drive down costs, we're in a process that is going to create ever rising costs. In addition to the concerns about energy, no one can avoid noticing the horrible outcomes in the historic flooding yesterday and the loss of life. The implications of the damage done is going to give rise to insurance premium rate rises for liability insurance, for homeowners, for cars. We're in a cycle of rising prices that we need to take charge of. So I would hope, and I would ask both through you, the commissioner, and through the industry, that we get concrete suggestions on what to do in terms of improving your negotiating ability with both the pharmaceuticals and with the hospitals, because it's clear to me that the system is broken and that the costs are being passed along to you and you're passing along to the consumer. And I think I did hear a suggestion about the medical loss ratio or being maybe the proper model. And I think there's an allusion from the commissioner concerning that, a medical loss ratio works in only one direction, as I understand it, is that as prices go up, the number of dollars collected in premiums and in profitability goes up. And that any reduction in costs could give rise to a reduction in profitability and in gross receipts. So I'd be asked that we look at those issues and consider them very strongly. I think we need stronger advocacy. I think we need stronger transparency in pricing. And we need to improve the negotiating ability of our insurance companies. And they need to ask for the tools through legislation. And I'm not hearing that today. And I'm concerned about that because the hospitals and the pharmaceutical companies, from the point of view that I hear so far, they seem to be winning the day. And I've not heard anyone ask us for the tools they need to rebalance that equation so that we're all working for a more effective, for more accessible, for cheaper and better healthcare. Because 9%, we're headed to a disaster with these types of rate hikes. And I'm not challenging that the rate hikes may or may not be justified by the costs, but we're not addressing the cost structure adequately. And I'm asking for help on legislative suggestions, particularly from the insurance industry that are supposed to be the overseers of the process. Thank you.
Thank you, Representative Meskers. And our next speaker in person will be Representative Holly Cheeseman.
Thank you very much, Commissioner. I want to thank everyone for being here today for this, as they say in the State Department, frank and meaningful exchange of views. I think we all, I hope in this room, have one goal, which is to make insurance affordable, accessible, and of high quality for all our residents. And as I said in my testimony last year, it is somewhat frustrating as we always seem to be in this circular firing squad where one entity blames another entity that blames another entity. I had welcomed the suggestion that everyone get in the room and discuss things. Enough of that. I hope that can happen at some stage. I want in particular to thank both Anthem and United Healthcare for remaining in the small group market. I think this is the most challenged market. I think we can do on the legislative side things to help that. I was extraordinarily disappointed that the move to create association health plans didn't happen last year, because I think for small businesses that would be a plus. I agree with you that the monopolistic nature of our hospital system is a real disincentive to bringing prices down. And indeed, I hope the quality of care from those hospitals could help drive prices. It concerns me that there's only one major hospital group in the state that participates in the leapfrog process, which actually rates hospitals on their quality of care. I would love to see more incentives, as you have mentioned, on rewarding good quality of care and perhaps not penalizing, but being not as generous with lower quality care. And I think that transparency in terms of the care that's delivered is important. And to the request that you tell us what we can do to help, people have used the analogy of those rate increases in electricity. Well, many of those rate shocks were driven by public policy decisions made in this legislature. And there has been a suggestion, and I need a valid one, that if public policy is the goal, it should be paid for out of the state budget. I believe it was Mr. Russo who mentioned that both Maine and Utah cover the costs of mandates in their insurance policies that are not dictated by the Affordable Care Act. Again, public policy made by this legislature should not be passed on to our ratepayers, whether they are insurance customers or electricity customers. Budgeting is about priorities. If bringing down the healthcare costs of our residents is a priority, why shouldn't we as a legislature look at covering the cost of some of those mandates? I would love to see something to address what I have told is a common practice, that copays on prescription drugs are based on the rack rate, not the eventual negotiated price. So if the rack rate's $1,000 and what the insurance company is paying the pharmaceutical, the PBM, is $450, the customer pays the 20% on the $1,000, not on the $350 or the $450 that's the rate. I think there are goals that we have in common. I think there are moves we can take as a legislature to lower costs. I look forward to doing something that will actually make a difference, but that will require the commitment of everyone involved: insurance companies, hospitals, PBMs, pharmaceuticals, the cost of hospital care. I'm looking at my personal EOB, $925 in hospital facility charges, accepted in payment $488. What's the real price? And we're told that commercial insurance is what supports the lower rates they pay for Medicare and Medicaid. So this is a crazy system. I don't know, apart from starting from scratch, how we fix it, but I do know there are steps we can take as a legislature to make it better. So thank you very much, Mr. Commissioner. Thank you, everyone, for being here. And I look forward to actually working on real solutions for our ratepayers. Thank you.
Thank you, Representative. And our next speaker joining us remotely, Representative Keith Denning.
Thank you, Commissioner. I appreciate the time to address the meeting. As a healthcare provider for over 40 years, one of the things that we probably should fix, and I would look as a legislative solution, is more transparency in the costs so that the consumer actually knows and has a choice as to what they want to purchase and where they want to buy their care. And I think in the discussion today, that's been left out of the discussion. And it seems like the hospital wants the customer is the insurance company. And the insurance company is the one who's supposed to manage the costs, when if the customer, who's actually the person who's going to get healthcare, could choose and say, I want to know what the costs are, or are mandated that those costs are presented to them. And also, they could share in the cost savings by saying, if you choose the one that's cheaper, we'll give you a 10% discount or a percentage of whatever you would save if you had not gone to the other provider. And in that regard, you actually bring the people who are making the decisions down to the personal level. As pointed out by the previous speaker, the standards of care are costs determined by hospitals in no way reflect the actual costs, nor do they reflect anywhere near what was negotiated and or why. Pharmacy benefit managers have no idea what they're making, what they're getting their money from, where the rebates are, who's getting the rebates. And while I hear that you're sharing the costs that you get from these savings, that you're passing them on to your customers, the transparency is not there. I would like to see much more legislation that would open up just the numbers on how we can get the consumer involved to make a better choice for their healthcare. I applaud everybody in the room for coming together. We need more work on this. We need more people involved, and we need more transparency. Thank you very much.
Thank you, Representative. And next, we will move also remotely to Representative Tammy Nuccio. Representative?
Thank you, Commissioner. I want to start out first and just really thank Representative Meskers. He and I have been working on insurance stuff for 4 years now, and I think we finally got it. So I just want to say everything he said, ditto. I only have one question for the insurance companies in the room right now, and that's Anthem. You had mentioned that mandates cost about $2,085 a year. I would really like to see the detail on how you came up with that, first of all. And then my challenge is actually for us. I listened to everybody here in the Attorney General's office, asking you to please bring forward legislation or sit down. I am glad, happy, thrilled, excited to sit down and have a conversation with you on how we can get the Attorney General's office more involved in looking at the monopoly of the hospitals in this state. I would like the Attorney General's office to take a stronger hand working with OHS and again, the Insurance Commission on putting in regulation that enables us to crack down on the benchmark. If we can penalize hospitals or insurance companies or whoever else is raising those costs by saying you are over the cost benchmark by X amount, either bring your costs down or we're going to fine you, maybe people will start to take us seriously. And at that point, I think that falls back on the Attorney General's office to really truly look into the monopolies. And from OHS's perspective, OHS approved the consolidation of these hospitals. Part of that comes down to whether or not they could prove the accessibility and affordability of these conglomerations of buying up other hospitals. I can tell you pretty significantly with the own data that we've just reviewed, they are not accessible nor affordable. So what is the recourse for us to go back and look at these consolidations and say you have not met the requirements you set forth, saying you were going to increase accessibility and affordability. So now we're going to do something about it. So the last thing here, I love the idea of an MLR for hospitals and pharmaceuticals, but at the key of this, affordability, asking affordability, whether or not an increase in insurance plan is affordable, gets back to the same exact thing that I just said. Claim cost, period. Hard stop. That is it. If we can control the claim costs, we can make things affordable. That falls back to us to enforce the benchmark, to have reasonable benchmark numbers, to have the Attorney General look at the monopolies, have OHS go back and review the applications for consolidation, and to challenge these hospitals that they have not met their duty. At that point, we can start pressing and say, we will not approve this rate increase because it is not reasonable, because you have not gotten the costs down by working with them. They all have the same mandate. And I would like to point out that once again, the hospitals are not in the room, and neither is pharma. So until we can have a true roundtable and address these issues, we're going to be here next year, and we're going to be talking about the same things, because the cost of care, which is the cost of claims, is exceeding the cost of CPI plus 100. I just went through breast cancer surgery, over $300,000 for that. I ask you in that room, is that reasonable? Is that what we think is reasonable? And how long is government going to allow it? Thank you.
Thank you, Representative. I think that brings us to the end of our list of officials. Is that correct, Ellen? In that case, we will take a short break. We are going to return, we'll do a 10-minute break, return at 1:20 p.m. And at that point, we will open it up to members of the public who signed up to testify. We'll see you in 10 minutes. Please take your seats. We are ready to resume. Please take your seats. We are ready to resume the meeting. Welcome back. We will now open this up to the members of the public who signed up to testify. I do ask that you limit your testimony to 3 minutes and state your name at the beginning of your comments. Allison, please proceed with reading the list of public speakers.
Liz DuPont, Andrea McDonough, Barbara Pierce, Elise Correa, Julie Andrews, Phil Brewer, Deborah Dauphiné. So we'll start with Liz.
Thank you, Ally. And please call each person as it is their turn to speak.
Liz DuPont.
Percent today ranks above Walmart, Chevron, Goldman Sachs, and Morgan Stanley on Forbes's 2024 list of the world's largest companies, public companies. Over the last 2 decades, we have seen a radical transformation in the way private insurers and our health insurance system more broadly operates. Major insurers have rapidly become one of some of the largest corporations on the planet, while working families they serve have continuously endured rising out-of-pocket costs, diminished access to care, and skyrocketing medical debt. This is because insurers have found paths to profit that no longer rely on their customers. The first of these paths has been discussed today through the monopolization of the prescription drug pricing process using pharmacy benefit managers, or PBMs. In just the past few years, major insurers, including CVS, United Health, and Cigna, have either merged with or purchased their drug price middlemen. The New York Times has reported recently that 3 of the largest health benefit managers now collectively process roughly 80% of all prescriptions in the United States. Hired by employers and government health insurance programs like Medicare, benefit managers are responsible for negotiating prices with drug makers, paying pharmacies, and helping decide which drugs are available and at what cost to patients. By holding exclusive control over the negotiations, availability, and coverage, insurers have effectively cornered the market. But instead of leveraging this power against pharma to lower drug prices, as they have promised, insurers have been caught doing the exact opposite. PBMs are consistently driving up costs for millions of people, employers, and the government, reports the New York Times. By negotiating prices upward and favoring more expensive brand name drugs, insurers have padded their bottom lines with exorbitant fees for their PBMs on each transaction. Now, CVS, Cigna, and United are making more than 60% of their revenues from PBM divisions. The second pathway to profits for insurers has been through government programs. Acknowledging that CID does not have oversight into public programs, it is important to know that private health insurers are increasingly taking over Medicare Advantage. They now administer more than 50% of plans.
3 minutes, if you could please conclude, sorry.
Thank you. Despite very serious concerns that they are inflating costs and denying people care. Also, United Health Group is under fire now for allegedly encouraging clinicians to overdiagnose certain conditions in Medicare Advantage plans. I'll close by saying it's time for CID and the state of Connecticut to take real steps to demand transparency around insurance company profits and self-dealings. We appreciate many of the comments today and the suggestions that hospital insurance contracts be submitted to the state and be publicly available. And some very good questions have been raised, and we look forward to the answers that will be provided by the insurance carriers. Thank you.
Thank you. But I do, just to state for the record, Medicare Advantage, we regulate companies for solvency. Medicare Advantage for market conduct is under the purview of CMS, and the federal government prohibits us from getting involved there. Just wanted to make sure that was clear. Thank you.
Up next, we have Barbara Pierce remotely. Okay.
Yes, hello. I'm Barbara Pierce. I'm the CEO of the Connecticut Hospice. And I joined this call simply to make sure that everybody realizes that there are other players in the ecosystem for the state healthcare environment other than simply two big hospital chains or three, depending on how you count them. And that we also are a licensed specialty hospital and an inpatient and outpatient hospice, now with a guide dementia program and outward-facing palliative care program. We struggle because Medicare and Medicare Medicaid don't cover the costs of our providing care, nor do the commercial insurers. And for us, a big problem we've had is that we've had severe delays in negotiating. And the only point I really want to make about the commercial insurers is that simply by not getting back to us for weeks and months at a time, we lose up to an entire year of insurance raises because our contracts aren't finished. And for us, we don't have any market power like the big companies. So I heard the three gentlemen this morning talk about the fact that they have to deal with people who have a lot of market power. We have no market power. We're much, much less expensive than any other way to take care of end-of-life patients, as I think has been amply documented elsewhere. But we struggle in order to receive rates that exceed not only what you get in any other setting, but for instance, in our case, we are hampered by the fact that for reasons of our own management, for many years, we did not get raises, meaning that it's off a low base. So we're getting offered rates that are less than 2% higher year over year. And then it takes us a year to get them, meaning that for 2 years, we get 2% on top of a very low base. So in one case, we got offered rates that are 20% below what a dog crate in a vet hospital costs to keep a patient overnight. So we are not keeping up with the pace of inflation. We are a far better and less expensive way to deal with end of life. We can take patients on DRGs. We can take patients who are GIP. We want to play our part. We want to step up and do our work, but we need help in terms of being a provider with no market power. So that's really all I had to say. I'm happy to answer any questions that people have.
Thank you.
Up next, we have Evilise Correa.
Yep, I'm here. Thank you. I'm having a little bit of trouble breathing due to COVID, so I'm sorry if I'm a little slow. I'm here to testify today against the proposed 2025 price gouging in healthcare. And I wanted to read off some numbers and facts. Starting with Cigna. So besides their PPP loans being forgiven, part of the rate increases that they're requesting, 172 million of that will be used to repay false claims as ordered by the U.S. Justice Department. Cigna threatened to leave the state if a public option were enacted, but then left the state anyways and laid off 500 people. They pulled out the small group market. They've been fined several years in a row, including this year. Their 2023 profits, despite these fines, 5.2 billion for 2023 and 2.1 billion in stock buybacks. Moving on to Anthem, who also had PPP loans forgiven. The Justice Department alleges over 100 million in Medicare Advantage fraud. They were fined in 2022, 23, and 24. Despite having to pay these fines, their 2023 profits, 5.987 billion, and they were able to purchase 2.7 billion in stock buybacks for 2023. Connecticut, I was able to find a fine from 2022, and their major investor, Molina Healthcare, as of 1 p.m. today, their stock price is $350 per unit. CVS and Aetna also had PPP loans forgiven. Express Scripts, which they owned, are being charged under RICO in California and are part of a class action lawsuit. They were fined in 2022, 23, and 24. Despite having to pay these fines, they made $8.3 billion in profits, and they were able to purchase $2 billion in stock buybacks. And then my personal favorite right now, United Health, who also had PPP loans forgiven and are currently being sued over algorithms being used to deny healthcare to Medicare Advantage customers. They were fined in 2023 and 24. They made that's not a two. That's 22.4 billion in profits in 2023. Stock buybacks, 6.7 billion in just 2023 alone. And as much as they're complaining about the healthcare monopoly, Trinity Health Network is currently out of network, and I happen to know that because my children are insured with them. So I don't think that customers and ratepayers should be footing the bill for their stock buybacks, for their fines, for their executive compensation, which I'm also happy to read off, but that is publicly available.
Your 3 minutes are up. Please summarize.
Thank you. And as these insurers fight against making charge masters at hospitals public, PBMs are proven to increase costs. And I would hope that the Insurance Commission does deny all rate increases. They don't need them. The companies are still turning a profit as Connecticut residents suffer. Thank you very much, and I'm happy to answer any questions.
Thank you. Ally?
Up next, we have Deborah Dauphiné.
Hello, can you hear me?
Yep.
Thank you. Thank you, Commissioner and others. I appreciate the time. My name is Deborah Dauphiné. I am a small business owner, and I have no access to affordable health care for myself or for my employees. Every year, the insurance companies ask for rate hikes. I testify against it. They get an increase, and they use these rate hikes to increase shareholder and CEO profits, not to help your constituents. I have a master's degree in public affairs, concentrating in healthcare administration, and served as the director of quality management for a behavioral healthcare organization and its provider network. I was responsible for creating, overseeing, and monitoring our healthcare quality indicators. Companies choose to measure what is important to them. We measured indicators such as connectivity of care, client satisfaction, ability to access care on a timely basis, patient-centered outcomes. These insurance companies measure profit outcomes for their CEOs and shareholders. That is what is important to them. CEO contracts provide for multi-million-dollar bonuses on top of multi-million-dollar salaries based on shareholder profits. Make the rich richer, charge their customers more to do it, and get even more millions into their own pockets. Do patients suffer or even die as a result of unwarranted delays or denials of what should be covered care? Do we not access care because we cannot afford their high deductibles, or do we delay care until a health issue has become far worse? They do not measure these. I have paid as high as $10,000 a year for my $6,500 deductible. Last year at this hearing, a legislator asked how many of their high deductible clients meet their deductibles, remaining basically freebies for them. Nobody knew the answer. It is not measured because it is not important to them. They measure and incentivize profits. Profits alone is why they are in business, and that is why they request rate increases to use the money that you approve for even more profits. They will tell you their sob stories, how they are in financial trouble and need your help. As a student, my statistics class included the book, How to Lie with Statistics. It taught us how to recognize when statistics are being misused. The insurance companies are really good at this. They cite their heavy losses, focusing on a single line item, not stating their overall profits were in the billions, perhaps even record-breaking, a banner year for the shareholders and CEOs. This is the type of situation How Do I with Statistics warned us about. As a business owner, I have no right to increase profits every year. If I raised my prices double digits, my customers would leave. I can't leave health insurance, though I'm at risk for over 30% of my income. I pay obscene rates so I don't go bankrupt, don't lose my house, don't harm my family if I become seriously ill. I don't access care if I'm sick or in pain because, as I said at the beginning of this testimony, I do not have access to affordable care. So here we are again. The health insurance companies tell you their sob story while having some of the highest profits of any industry in the nation. You've heard horror stories of customers of these insurance companies, human beings who are suffering, whose needs are not being met. The companies will likely once again attempt to bully you and the legislators of this state, saying they will take their business and jobs out of state if you do not bow to their demands. Let's make this hearing result different. Please do not approve any rate hike. Do not take money from the poor to put into the pockets of the wealthy. It is not a success to give them less than they asked for. It is only a success if you give them no increase at all. I ask you to say 100% no. The millionaires will be okay. Thank you.
Thank you.
Lastly, we have Phil Brewer.
Hi, I'm a retired emergency physician. I've been in Connecticut since 1988 when I came here to help start the emergency medicine program at Yale New Haven Hospital and Yale Medical School. And I'm here as a representative of Physicians for a National Health Program, which is an organization whose goal is to improve and expand Medicare to cover the entire population. In a rational system, this hearing on rate increase request would be completely unnecessary. But unfortunately, the driving force behind our system is profit making. It's a system of exploitation. This may be rational from the standpoint of for-profit entities, but not from the standpoint of individual citizens, nor of the good. Exploitation by the two hospital systems have established a dual monopoly in Connecticut, and they reward their executives with exorbitant salaries. Represented here today is the for-profit insurance industry that feeds the beast every year after by negotiating inflationary contracts and also by self-deals of ownership of pharmacy benefit management companies, or PBMs. It's the height of irony that the health insurance industry complains that the major source of their cost increase is pharmaceuticals, but they fail to mention that the PBMs, which they own, are a major profit center. My recommendation is the following. Stop the hand-wringing over rate hikes followed by their reluctant approval, and instead do the following. Divest pharmacy benefit management companies that are currently owned by health insurance companies. Set a minimum medical loss ratio at 13% rather than the currently tolerated 20%. Cease upcoding schemes that insurance companies are practicing. Adopt a vigorous policy of investigation of overbilling, which is rampant in the industry, as evidenced by Medicare Advantage overcharging by as much as $140 billion per year. And I know that you don't directly regulate Medicare Advantage, but if it's happening there, you can be sure it's happening elsewhere. Prohibition of ownership of medical care and provider organizations by private equity firms. Public access to contracts between medical providers, so we have that transparency to help form public opinion and inform our legislators as to what we would like them to do. Establish acceptable parameters for pre-authorization and claim denials using the traditional Medicare system figures as a benchmark, and abolition of the system of closed provider and facility networks to be replaced by publicly available reimbursement tables using Medicare reimbursement rates as a baseline. And I want to repeat what others have said. I appreciate that the insurance department has moved these hearings to the legislative facilities and made them much more available to the public. And I really hope that you're just going to say no, or perhaps approve increases that are consistent with inflation, but not these year after year, 7, 8, 9, 10% rate increases. It breaks my heart as an emergency physician to listen to somebody who is hardworking, has a business, and cannot afford health insurance, and they will lose all of that. And I like to say that in my career, I've saved many, many lives, but I've also run many, many people into bankruptcy once they got the bill for my services and the services of my hospital, and that's just not right. So again, thank you very much.
Thank you. Thank you all for sharing your insights and your perspectives during today's meeting. Before we conclude, I just want to check, make sure that we got to everybody on the list. Allison, we did. Wonderful. All right. Now, the only other thing that I would, I'm just looking around the room to make sure there are no additional speakers, and there clearly are not. We're going to conclude this meeting, but I want to repeat what I said at the beginning. And given the heavy rains, the 1 in however many thousand-year storm that we just had, the insurance department website will have or does have resources available, ct.gov/CID. Tomorrow, Wednesday, August 21st, from 1 to 2:30 p.m. Eastern, we will have a virtual claim center open. You can log in either Teams, WebEx, however they do it. But if you go to our website, you will see the link to that. And if you have specific questions, you can call us at 860-297-3900 or send an email to insurance@ct.gov. Once again, I want to thank everybody who took the time out. I know everybody's schedule is busy, took the time out to be here today to share your insights, to share your opinions, to share information. They're greatly appreciated. This is, as we all know, a difficult process. We've got a great team here from the department that are working on it, and shortly we will be announcing the rates that we will approve for next year. Thank you all. This